Okay, ladies and gentlemen, we're going to make a start. And because we are live streaming, I have to read this little notice and introduction, which is entitled Chairman's Announcements. So a warm welcome to those attending and also our viewers watching live on the Council's YouTube channel, Hillingdon, London. This is a meeting of the External Services Select Committee, and my name is Councillor John Riley and I'm the chairman of this meeting. A key role of this committee is to monitor the performance of local public services within our remit and to hold in-depth reviews on topics of residents' interests. We engage with a wide range of external witnesses in our activity, which can include community groups, residents and subject matter experts. Where we identify areas for change or improvement, we make recommendations to the decision-making cabinet. Details of the business to be considered today are shown on the agenda, copies of which are available in the room and also accessible on YouTube underneath the broadcast. For those present in the room and intending to speak, please note that you will be filmed and any statements you made will be recorded and made public. And for those in the public gallery, you won't be on the camera. That's not quite right because of the layout of the cameras in this room. Some people in the public gallery, especially on that side of the room, which is, I assume, why you've all sat over there, will be visible on camera, and the makeup room is just over there. A reminder to councillors and officers, those speaking today, you should turn on your microphone with the button on when speaking, and this will ensure that you can be heard in the room and also by those watching online. It suggests that I then go around asking everybody to identify themselves, but there's far too many people for that, so maybe we'll do that as and when people speak, but just for the first time. Before we get started with the main agenda, some quick housekeeping rules. We're not expecting any fire drill this evening, so if the fire alarm goes off, follow Nikki to the fire exits out of the building to the designated meeting point, which is the Civic Centre forecourt. Mobile devices, for those in the room, please switch off any mobile phones before the meeting starts or put them on silent. Some of us will be using our tablets to look at the agenda and read reports and so forth. And apparently you are encouraged to give feedback about this meeting, and there are feedback forms available at the back of the room, and there's also a version online under the broadcast for anybody who wants to do that. If there are any Part 2 matters, we shall go into private, but I'm not sure what there are for these purposes. Good. So we will start. And of course, welcome to everybody who's come here this evening. So we'll start with apologies for absence and to report anybody who's here as a substitute member.
Chairman, we've had apologies from Councillor Dennis, and Councillor Brightman is here as his substitute.
Thank you very much, and great welcome to Councillor Brightman. Any special declarations of interest about matters coming before the meeting? No, thank you. All right. And all things will be in public apart from those which are in part 2, but as I say, I don't think we've got any of those. Right, minutes of the last meeting, 12th of June. Now, we've had a couple of requests for amendments to the minutes that were sent out, and I hope everybody's seen those sheets. One was in relation to the cancer screening diagnosis, and then in that paragraph, and then one relating to the bowel cancer item in that paragraph. So if everybody's happy with those amendments, are those agreed? Thank you very much. Okay. Anything arising out of those last minutes? Some of the things that were in those minutes we'll pick up with the health trusts later. What we've said is, because we've essentially got 2 parts to this meeting, the first being the hospice provision in the north of the borough, and the second being the health updates. We've, I suspect, with the exception of possibly 2 people, we've asked that the representatives from the health trusts don't necessarily need to turn up unless they wanted to watch this next bit until 7, because I think with an hour for this first bit will we've got so many other things to do later on that pretty much we said an hour for this first bit and then an hour and a half for the health update. So that's why you can see quite a few empty spots for the moment, because they'll be arriving later. But do any members or anybody have any things they want to raise from the last minutes? No? Okay, can they be agreed? Thank you very much. And it was only one lot of minutes from last time. Yes, it was. All right, good. So we can go on to item 5, hospice provision in the north of the borough. So, as pretty much everybody will know, in our last meeting in February, we got to a certain point with regard to our, as it was then, long-standing inquiry into Michael Sobel House and the provision of hospice provision in the north of the borough, as far as that was concerned. And we got to a point where I think the committee were very pleased that we'd got what seemed to be unanimity on the part of all those concerned. And we were moving reasonably towards a point where we were hoping to have Michael Sobel House, the inpatient unit, reopened, or well on the way to being reopened. We understood that there would be commissioning for Hillingdon, for Harlington Hospice to get involved, and things were in the early stages, but that's the way it was all going. And as we all know, Eastern North Heart's heavily involved, and both the trust and, as it later turned out, their commissioners. And to an extent, some progress has been made. But it became apparent to us in the last few weeks that not as much progress as we had hoped had been made. And a few other meetings were undertaken to try and find out what was going on. Of course, we can't keep having meetings of this committee in order to deal with every small step of the way, so we have other meetings outside. And it was very interesting because it became apparent that a significant number of other organisations were involved in this whole process. And because the NHS is a very large organisation and takes a long time to make decisions, things had slowed down a lot. That's a very simplistic and generalised way of putting it, and as I can see from our colleagues. But I think it's great that we've got the people we have here at the moment who can give us an update. It is, without question, and I say still advisedly, this committee's desire and aim to have Michael Sobel House reopened. There's no question about that, and there is support from that as far as the whole of the council is concerned. I've made sure of that. It's really a question of having to get through what is also, without question, a labyrinthine sequence of events and triggering decision-making, which seems to be incredibly complicated for something which we think, and I know a lot of people sitting outside this table think ought to be a fairly straightforward operation. I can tell you that a lot of people have been working incredibly hard to try and achieve this, but it is a bit like walking through spaghetti with your Wellingtons on. So I'll ask the various people who are here who can help us with where we are now and ask for suggestions about how we move forward, which I'm pretty sure will involve some of us going out and talking to newly identified, or at least newly identified to us, people to try and bring this thing to a more speedy conclusion than it seems to be at the moment. So we'll start with Caroline and then we'll move on from there.
Thanks, Chair. So I'm Caroline Morrison. I'm the Managing Director at Hillingdon CCG. I suppose I'll run through the positive progress that we've made first, and then maybe come back to the parts where we are struggling to maybe move as quickly as we might like. So I think the committee will remember that back in February at the last meeting of this, we'd confirmed what our commissioning intentions were regarding the future of hospice care in the north of the borough, and we'd written to Eastern North Hearts Trust to confirm that we were planning to recommission a service that would cover inpatient hospice care, the day centre-based palliative care service, and a 24/7 consultant-led telephone support service. Following that, we then launched a sort of a governance process to determine who would be able to deliver that service, and I'm pleased to say that Harlington Hospice were awarded the contract, and we went through, for those who like the jargon, an OJU compliant process. So that was all published on the European Journal of Contracts, and it was up there for a month. We had no challenges, so we were able to progress with that. Then I suppose we got to the point of really wanting to discuss the details of mobilisation of the service, and there are a number of meetings arranged with Eastern North Hearts, really around the key constraints for us and for Harlington, which are around workforce and estates. So in essence, we have a provider who can deliver those three elements of the service, but at the moment we don't have anywhere to provide it from, and some of the workforce may or may not be sort of potentially able to move from the existing or the pre-existing service, I should say, that was delivered in Michael Sober House. A number of meetings, unfortunately, were cancelled by Eastern North Hearts Trust at fairly short notice, and we went through various processes of escalating the fact that we didn't really seem to be getting anywhere with regards to getting some clarity around, to be honest, either the future of the estate or the management of transition, which I suppose we were under the impression there had been really an agreement reached, that there would be a sort of collaborative approach to moving forward and transitioning whatever the future service might look like into a new home or into a home in the north of the borough, but we didn't really seem to be getting anywhere. So this was escalated then, directed through to the Chief Operating Officer at Eastern North Hearts Trust, a lady called Julianne Smith, and then at the same time to Eastern North Hearts Clinical Commissioning Group. Now, Eastern North Hearts Clinical Commissioning Group then took the step of asking all associate commissioners to the service to confirm their commissioning intentions, due to the fact that Eastern North Hearts Trust appear to have wanted clarity from all commissioners of that service regarding their future intentions for the service. So, as Councillor Riley said, at Hillingdon CCG, we, to be honest, accounted for the largest minority of that activity. So I think we're around about 44% of the activity Hillingdon CCG historically in that unit. I think the next largest sort of commissioner of that facility was Harts Valley CCG, and then there are a small number of other CCGs, including Brent, Ealing, Harrow, where we had a very small number of, there was a very small amount of activity that went into Michael Sober House. But Eastern North Hearts Trust wanted clarity from all commissioners of the service regarding their intentions going forwards. So that unfortunately has taken a while. So whilst we obviously provided our intentions back in February, the deadline requested for colleagues to confirm their intentions was the 5th of July, which was the end of last week, and there will be a meeting held on Thursday on the 11th of July for all of the commissioners with East and North Herts Trust to review the activity, review the commissioning intentions, and to agree really then the timelines and the next steps around the impact of that on the current service that East and North Herts provide. I've asked specifically for a couple of things to be added to that agenda. One is the East and North Herts Trust intentions around the Michael Sober House building, because it does seem slightly odd that we are not able to have a conversation with them about that, bearing in mind they are not currently in there or using it for any type of service provision and have said publicly that they wouldn't be. So that is an agenda item for that conversation, in addition to the sort of activity and commissioning intentions. And then the other one ties into another conversation, which is around the Mount Vernon Cancer Centre and just understanding what, if any, the interdependencies are between the specialist palliative care service that East and North Herts are saying they are going to continue to provide, and the cancer services that are currently on that site, because clearly going forward we want to make sure that we manage any potential risk around those, rather than sort of not have the foresight to be able to plan should that be any kind of an issue. So I suppose the headlines are that in terms of identifying a provider, and I'm sure Steve and Michael can talk sort of more concretely about how those relationships and the work those developed. So that's very positive, but the challenges really have been the very sort of specific ones around estates workforce and just being able to move forward on the plans.
So to put it in horse racing terms, we've got the horse in the in the box, as it were, at the start, up to the starting gate. We just need the levers to open it. Okay, good. I like things simple. All right. The idea of there being a relationship between the inpatient hospice care and the general cancer service that's provided, that's been the subject of a recent review, and I don't think it's reported yet, but next week I think it's reporting. Do you see any significant impacts between those two at all?
So, having not seen the outcome of the report, I couldn't say now. I suppose just bearing in mind previous experience and what we've just gone through with the work around the hospice, I think it is worth us being very clear and having a very clear statement from East and North Herts Trust about whether there are or are not interdependencies between those two services. And I think once we see the report, I haven't seen it yet, but as soon as we do, then I think we'll have a better informed position to be able to ask some of those questions from.
And I think, and also, as you say, East and North Herts Trust did say to us last time, again putting it colloquially, that they were happy to step back, and part of that would be that they would, because they are, as it were, tenants to Hillingdon Hospital Trust of the Michael Sober House building and the site, that if they were to, as it were, hand it back, it would be it should be a fairly smooth transition, because of course, and I'm looking at to here on this one, it would be because, and again we understood from Hillingdon Hospital that they weren't worried about it because there was a commissioned organisation ready to go, as it were. So the transition may be a bit bumpy in terms of the work that needed to be done and that interim period, but nevertheless. That wasn't something that concerned Hillingdon Hospital Trust as the landlord, so that wasn't a barrier as such in any way. So that was all right. All right, Steve, where are we as far as Harlington are concerned? And sorry, if anybody, of course, any other members who want to chip in as we go along, that people must ask questions.
Oh, good evening. My name's Steve Curry. I'm Chief Executive at Harlington Hospice. As Caroline has already stated, We've worked with Hillingdon CCG around awarding the contract, and that's gone to plan. And we've had several meetings and given them project plans and work plans to deliver on that. With that point as well, we've worked very closely with key partners. So with Hillingdon Hospital Estates team, we've worked with some architects to look at what adaptations and improvements needed to the building to make it adequate to provide a safe and to be honest, good enough service, but to actually be at least, if not better than it was prior to actually closure, but definitely around a safe service. And we've got plans drawn up with that. We've sat down and done a lot of work with the charity, Michael and Ian, particularly around what work needs to be done to the building, and they've taken some steps to actually start putting in place actions to make that work. We've met as boards, with the two boards of the charities have met, and we've agreed formal structures to joint working. We've also been had contact with all the surrounding hospices to make sure what we're planning there is actually fits within the current services, and to get an idea of what the lay of the land is, particularly with Peace Hospice in Watford, St Luke's in Harrow, and Thames Hospice in Windsor. The work we've done with the charities to look at joint communication strategies. Our fundraising teams are now working collaboratively on that side of things. So everything's all right that way around. When we were first given the contract, there was two rate limiting steps. One was the estate, the building itself, and the other one was actually particularly getting a lead physician, medical director in post. We've actually been able to appoint to that position, and we've actually recruited not a full-scale team, but enough of a team of nurses and healthcare assistants ready, waiting on our books, ready to start the service. We've actually done everything that we needed to do to be open when we were wanting to be it. The only challenges we've actually had is that prior to actually getting awarded the contract, actually discussions with Eastern North Hearts NHS Trust have been very positive. Michael, myself and Caroline have sat in several meetings over December and into January with them. But as soon as we were awarded the contract and wanted to actually move them formally into discussions around the GP arrangements of staff, etc., that's when meetings were cancelled with less than half an hour's notice, and not being able to actually re-get. So that's now become the major stumbling block, is now the building. And also there will be staff who will actually qualify for GP transfer to the service, with the service. So we want to make sure that they're not also put at risk. We've worked very closely with our other Hillingdon Health and Care partners in terms of the palliative care consultants at the hospital, the palliative care team that run by C&WL, so that everything's ready now in terms of pathways of referrals, etc. But now the block is the building.
How long would once you get the go-ahead, and it may be that the outcome of this meeting on Thursday, I think, reading between the lines, Caroline's hope is that we move things forward a lot on Thursday. Are we likely to get a definitive answer from Herts Valley, number one? And number two, if we are, how long from... Because everybody else, I think, all the other commissioners, and if I can use this phrase, are sort of minor commissioners, because it's Hillingdon hold a large proportion of it, as do Herts Valley. And between the two, I think you hold more than 50%. So if they're in agreement, and I had understood they were, but if they are, and the others have all indicated, I think, that they are in agreement with us going down this route, then from then, how long will it take for the work that you've identified, which is a lot less than we were told previously, to be done so that we can aim for an opening?
I will probably pass it over to Ian and Michael. Ian has been working very closely with Julie Wright, who's our Director of Clinical Services, around this side of things. And I don't know the full details of it, but I know particularly Ian, whose professional expertise is much more appropriate to answer that question.
All right, Ian.
Chairman, the work's actually fairly minor. It's redecoration, skirting. Sorry? Just a bit closer. Hear me now? The work that's to be carried out is, in relative terms, it's quite minor. It's redecorations, moving some doors around, adding in 2 or 3 additional washrooms and toilets. The overall period of time is difficult to judge because we've got to get contractors on board. We have a contractor who's willing to work with us, who's worked on other hospices. We're heading into the summer period, but my exercise would be to try and get somebody up and running in in 2 or 3 weeks, and then after that, it's probably about 6 weeks' work to get the whole thing finished.
There was a lot of talk, as you know, previously by East and North Herts about extraordinary numbers in terms of what it would take to get the building usable again, and we've got around that, as it were. But some of their references were to equipment and putting in new equipment and all that sort of thing. Is that also something that's on the, not to the same value that they were talking about in the millions, but in terms of what's needed?
So, Chairman, I'm Michael Breen. I'm Chairman now of Michael Sobel Hospice Charity. Just to introduce myself to everyone else. In relation to the building works and the equipment, there is a fair amount of equipment that's already owned. We'd already bought that across the years. Most of it's being stored in the IPU at the moment. Some of it is spread across the other parts of Mount Vernon's site. So we would have to do some work to make sure we've got that. Our belief, together with Harlington, is that we have sufficient to get the thing up and running. There will probably be an ongoing spend thereafter. Excuse me. One of the issues we've had is property, because although there are plans that have been put in place, the first costing of those have been done by a firm of architects for Hillingdon Estates and priced up by a firm of quantity surveyors. Because we're a charity and we need to make sure that we look after the way that we spend money carefully on behalf of our supporters, we want to do a second costing on that, and that's where Ian has been having the conversations with a firm of contractors who, as he says, are specialists on hospice work, and they're prepared to do this work also on a no markup basis, so a cost basis, which is excellent. But before we can do any of that, we do need to have a conversation with Tahir, because we need to get access to the building. And there's a confusion there, which has upset the supporters of Michael Sobel Hospice Charity. So Michael Sobel, 42 years ago, put forward £1 million to build a hospice building, and the condition for doing so was that it would be used for hospice services only, that the NHS would run it, and that additional support would be made from charitable donations, and latterly that of course has been us as the charity. That was the first building. That was extended later to create the day centre. The day centre is the only part that's being operated for hospice services at the moment because the IPU is closed. Later, there was a building resources block built, again using funds raised by the public. Same purpose, need to be used for hospice services. It's currently being occupied by Research and Development of East and North Herts Trust, not being used for hospice purposes. Then we have another building that we used our money to build, or the charity's money to build, which is the Charity Fundraising Office and Education Centre. That is being used for fundraising at the moment. So we need to actually re-establish our right to use on the conditions that were there, because our public, our supporters, are quite rightly saying to me, how come we built the buildings and we can't get access to them? Now we can't, and we've always known that we can't own the land. Okay, but that's not the same as having a condition that is being no longer applied. So we need to do that, and we've been trying to get a... Oh, it's dreadful, sorry. We, for some months now, have been trying to get a meeting with Hillingdon Estates, but there have been changes there. Tahir's relatively new in the post. We haven't had that meeting yet. In fact, Tahir and I have met for the first occasion this evening. Pleasingly, we've agreed that Ian and I will meet with him very shortly to discuss that further. But of course, that's a frustration in relation to the time frame. It's a frustration for all of our supporters. The TUPE process that Steve referred to is also a frustration for our supporters and for the staff that work within the day centre. We have continued to support the day centre fully, paying £420,000 a year, so we still need income. We therefore still need the support of our public. And the support of our public is generally saying, what's happening? And what you described at the start of the meeting is exactly the case. We came away at the end of February thinking, right, we've got something to get on with here. And here we find that we're 2 days away from a meeting to discuss the way forward. That's really frustrating. And it makes it very difficult for us as the charity to maintain the support of our supporters. At the same time, what we find is that on the agenda for the meeting on Thursday, it actually says that East and North Herts CCG will ensure that the process is carried out properly and that the future service provider will be properly chosen, and that the services as currently being supplied in at the Michael Sobel Hospice will not be worsened, effectively. The IPU is closed. There is no palliative care, end-of-life palliative care, in the north of the borough at all. The day centre is there. There are various therapies. There's no bereavement counselling. The people that are actually admitted into wards 10 and 11 are cancer patients. So if anyone has a condition that is not cancer, they are not receiving that in the north of the borough. So we, as a charity, have been saying to our supporters, that's what we're pushing for. That's what we want to have. It's more than a year now, and it's 4 months since our last meeting. And now we're finding that the CCGs, who we were perhaps not fully aware of, in realising quite how many there were, are causing a problem. I had a meeting with Sarah James, Lucy, from East and North Herts, on the 1st of May this year. And she wrote to me saying, please be reassured, we are keen to make this transition a smooth and positive experience for all. It's not very positive, and it's certainly not very smooth. Sorry.
As you'd have told from earlier on, we share your frustration, and we had understood as a committee that we were at the start of something back in February, and also and a lot of the people who are here now were here then. East and North Herts essentially said that, and I had a meeting with the Chief Executive of East and North Herts Trust, and a second one last week. And again, they reiterated that they're keen to make sure that this all goes ahead. But there seems to be some procedural blockers which I don't understand, to them, as it were, undoing the key or whatever it is, undoing the bolts or letting the chains go or whatever you want to expression you want to use. And so if it means going around talking to the other commissioners or the other commissioners who are needing to be nudged on this, then that's what we'll do. I'm hoping that the meeting on Thursday, and it may be that some sort of written representation from you along the lines that you've just explained, to Caroline, so she can take it to the meeting to say, look, this is the background. This is not just the background, but this is where we are in terms of provision. I mean, it all goes back, obviously, to the chaotic and hopeless way in which this all started last year, and the way in which East and North Herts dealt with it. And one of their senior people came along in February and said that apologised for messing it up. And I would have hoped, and I stressed this to the chief exec twice, that given that acceptance and given the way in which they saw it, or that we having explained it to them, that they came to see it, that they would have got on with it. But to then introduce, as they did, this additional element of we need to make sure that all the commissioners are going in the right direction. Well, how hard would that have been, I rhetorically ask, any more than a phone call, even if not an email, just for them to say, for East and North Herts Trust to say, right, hands up all those who think this is a jolly good idea, metaphorically, right, here we go. And then to go to our commissioners who are leading on this, as we would want, and to Hillingdon Hospital and say, right, this is the direction of travel. Off you go. Over to you. And that's where we thought we were in February. So the frustration has has caused itself to create a few more meetings and to try and get the push harder. So Thursday's meeting will be very, very important. And if it does need another round of meetings offline, as it were, then that's what we'll do. But one way or another, and I've had meetings with all of the parties, as you know, Michael. One way or another, we will get this sorted. But the fact that it's taken a little longer than we'd hoped is unfortunate. Councillor Roddier.
Thank you, Chairman. I don't know where E&H are tonight. I mean, it's so disappointing that they have a leading role in this decommissioning process and that they haven't even bothered to turn up. E&H CCGs and E&H and Eastern North Hearts Trust's handling of this decommissioning process has been absolutely abysmal. It is completely farcical. How can you insist that CCGs put in place alternative arrangements for patients, given that the IPU has been closed for a year? There obviously are alternative arrangements in place, and this has been at the heart of the delay and the reason why it has taken Hearts Valley so long to confirm that they are on board. Something that's of great concern, actually, is that Michael Sobel Hospice have something called a resource building, and E&H have actually taken over this building. It was paid for by Mr. and Mrs. Elphick, who were from St. Albans, and they died at the hospice in 1988. I don't think when they left this in their will, they intended for it to be used by E&H. It was given to the hospice. I don't believe they sought the permission of the charity before occupying it. I don't believe they're paying any rent, and I don't think they've got any plans to leave. And it's a shame that they're not here tonight, and we can't address these questions to them direct. The community have been waiting so long now to see this hospice reopen, and whilst we've got Hillingdon Hospice here, will they commit to allow the charity and Harlington Hospice access to the building? Because we're being blocked on quite a few fronts, and we need to start unblocking things in order for this process to move forward. I do think Hillingdon Hospice should do the right. Hillingdon Hospitals should do the right thing tonight and commit to allowing the charity and Harlington Hospice access to their building. There's also concern in the community. There's also concern in the community, and Chairman, I must talk about this, that there are actually plans for Hillingdon Hospitals, who own the land, to sell it. There have been conversations going on about the value of the Michael Sobel Hospice land, and forgive me, I don't know the names, but the buildings either side of it. And the value is said to be £32 million. This is if they were to sell it off for sort of luxury housing developments in Northwood. All I want to say is that their Eastern North Hearts have actually been asking Hillingdon Hospital for a financial stake in this land. I do not understand why they would want a stake in this land if there was nothing in it for them. And again, I think if we have some sort of clarification tonight from Hillingdon Hospitals that there are no plans to turn the land on which Michael Hospice is based into any sort of housing development, that would be also greatly appreciated. And the final point, I promised I would talk about this, is that Dr. Laycock, who's with us here tonight, was one of the first end-of-life doctors at the hospice. And with the help of Princess Catherine of Serbia, they went on to set up 3 hospices in Serbia, which are actually based, they're an exact copy of Michael Sobel, and they see it as their mother hospice. I know that Princess Catherine is watching tonight, and she wanted me to express on her behalf how keen she is to see the hospice reopened. So we've got 3 Michael Sobel hospices in Serbia and none here.
Thank you. We'd had a communication from Princess Catherine, which was very much, as you say, in support of keeping things going and hoping that things can be dealt with as soon as possible. And I know she has kept a very keen interest in the whole thing, and we're very grateful to her and for her input and assistance. I know, Tahir, that this probably wasn't something you were necessarily expecting as far as this part of the evening was concerned, but obviously it's a big issue for us and a big issue for the community and for everybody involved. I don't know to what extent procedurally or legally as landlords you're able to say whether or not access can be gained just for some preliminary views to be taken or looks to be taken. I know that when there was a seeking of access, it was either denied or not possible in the relatively recent past, again on the basis of various complications. But is that something you can help us with?
Thank you. My name is Tahir Ahmed. I'm the Executive Director for Estates and Facilities at Hillingdon Hospital NHS Trust. In relation to Michael Sobel House, I will add that I've now been at the Trust for just under a month, but I have taken this matter personally to investigate a little bit further. There are indeed complexities in relation to land and title. Get nearer the microphone. Certainly. Can you hear me now, sir? Is that better? Thank you. In relation to the land and property title, I have made investigations through the legal process of our legal department, and they have confirmed indeed that Hillingdon Hospital is the freeholder. Can't still hear me. Let me try and move it this way. How is that? Is there a volume? I don't know. It's on. Right. I need to be even. How is that? Perfect. Marvellous. Right. Okay. So indeed, Hillingdon Hospital is indeed confirmed as the freehold landowners of the land and property that resides at Michael Sobel. We do also have what is known as undocumented tenancies pertaining to East North Herts. Now, one will know that where there are undocumented tenancies, that adds a layer of complexity because an unwritten lease is more difficult to manage compared to a formal documentation which prescribes the occupancy of that particular tenancy. We are at Hillingdon Hospital committed to supporting Harlington Hospice with their agenda for occupation over at Mount Vernon Hospital, with indeed an eye on the future development of Hillingdon Hospital's estate, of course. I have met with Julia Wright, the Director of Nursing and Clinical Services at Harlington Hospice, and we are now collectively pursuing other alternatives in which we may be able to expedite occupancy, whether that is in a temporary situation in anticipation of the formal occupation of Michael Sobel House. We may be able to interject and have a direct covenant with the hospice, although this may result in getting formal discharge of any obligations and rights that East North have in terms of the actual Michael Sobel House, and that's something that we will continue to pursue in parallel with the hospice as well. We've discussed the works that are required, and we're quite satisfied that subject to a formal scope of services being provided, we don't envisage any problems in supporting that work being undertaken as a matter of urgency as well. So at the moment, notwithstanding the request on space for the hospital leading up to the winter pressures, which we are indeed planning for already, we have identified yet other space which could, as an interim, be used. That is currently being explored, and we will revert back to the hospice once we know more about that.
If on Thursday, if I've got this right, if all of the CCGs essentially say the same thing, that they're all going in the same direction and they all want to do the same thing, which is aimed towards opening or reopening the hospice in the Michael Sobel House unit, and as a consequence, and if that's the problem that Eastern North Herts Trust have got, that they haven't got the say-so of all the CCGs, and then they do, and they are then able to, because they are the tenants at the moment of the building, and that they are, as they said they are, willing to relinquish that tenancy without any loss of anything, as far as I know, having spoken to the Chief Exec a couple of times now. You would be content to hear from them that they are relinquishing the tenancy, therefore it lies in limbo in a sense until there's a formal agreement with the new team, as it were, which wouldn't take terribly long because the new team are all saying we're ready to go. Is that an accurate sort of hope for a flow chart, as it were?
Yes, I would agree. I think if we are able to agree principal heads of terms relatively quickly in terms of duration and indeed the scope of works or services, then I'm pretty certain that we can move at pace to support that. But of course, it would result in East North Hearts formally declaring their or discharging any obligations in that undisclosed documentation that they have in terms of their ownership.
Well, see, they've to us they said that in February, and in large part it's been said to me twice now in meetings with their chief exec in terms of their intentions. And for our part, I don't think we can see what the barriers are once that's been... It may be for all sorts of legal reasons or procedural reasons that has to be done. But once it's done and communicated to you as the landlord, and literally communicated rather than triplicate, restamped and all the rest of it, then that should allow, shouldn't it, you to be able to, without any worry of comeback, give access to the building so that the team can see where they are.
I would hope it would be indeed as simple as that. Of course, there is the matter of just seeking the usual legal advice on both parties to ensure that that is formally documented. But of course, I personally feel that it's something that we would be able to facilitate relatively quickly.
Because the other thing that we discovered during the course of this whole investigation is that the formality of the relationship between East and North Hearts and yourself, well, not you, but your organisation, and the status of Michael Sobel House is somewhat lost in the mists of time. And trying to find any sort of formal documentation that sets out who's responsible for what, to an extent, may have had an impact on how the whole thing went wrong last year, in terms of responsibility, in terms of who should have been doing what, telling who, and all the rest of it. Because there have not been, as far as we could find, any clear lines of accountability and responsibility from a much earlier time. All right, that's good. Okay. So, Caroline, we can aim to try and use this meeting on Thursday as something of a jumping off point, even though it's a bit late. And I think it might be an idea if Michael can send you something to take to them with the force that he's just said to us. Tahir, thank you for that. That's very helpful. All right. I think that's probably as far as, unless you've got anything else you can pitch in with Caroline as far as this is concerned.
I think, as you say, it's really a case of trying to get as clear a commitment as possible on Thursday regarding timelines and next steps in the process. And I think potentially also just being very clear about the fact that, to some extent, the sustainability and viability of the current service is a slightly moot point, in as much as we don't consider that the current service exists in the same form as the previous service anyway. So I think as much as we can kind of move forward towards a resolution after Thursday, that's what we'll aim for.
Would it be of any assistance if we were to, as representatives of our residents, to send something to that meeting, again through you, along the lines of strength of feeling, along the lines of the fact that it's all very well saying that things... I mean, I remember sitting here listening to the people from East North Hearts saying, you know, how they were doing the very best that they could in relation to the whole situation, but frankly, moving people into those wards 10 and 11 and doing what they were doing wasn't better, it wasn't even similar, it was just hopeless. Sending something to that meeting, setting out a few points in order to assist in moving things on.
I think that would be helpful. One of the things that we have been sort of repeatedly requested for clarification of is the process that we've gone through as a CCG in terms of consulting and engaging the public in our commissioning decisions around Hillingdon Hospice and moving forward. So it would also be helpful to have something in there which is a statement of the fact that this has now been to a number of public meetings and that reflects the strength of feeling of the local community, because that does seem to be something that we are being repeatedly asked to provide assurance of, so that would be helpful.
I don't think there can be any question about the strength of feeling of our residents and of the public in general. I ask rhetorically, can there? You're not allowed to answer, thank you. All right, I think that's probably as far as we can take it tonight, unless anybody else... Councillor Lakmana.
My name is Councillor Lakmana, and just a couple of points for our information. Wards 10 and 11 were being refurbished. Does anybody know if those are back in operation because patients were moved from there?
Yes, 10 and 11 having refurbished, and the service is back in wards 10 and 11. I mean, what I would say, because you keep talking about, this is talked about in terms of hospice care for the north of the borough, I think I just want to clarify, because the service that Michael Sobel House provides is acute symptom management, which is for those people who've got really really quite severe medical needs, and it actually is the whole of the borough that actually patients from the whole of the borough go to that Michael Sobel House. And at the moment, because there isn't additional hospice space in the surrounding hospices, those patients are currently being cared for in acute wards, and in situations where they can't have the wraparound hospice services, and that's our teams are working very closely almost on a daily basis with their colleagues in the community teams, trying to find appropriate spaces. And that's the bit from our point of view, the frustration is that people are in the wrong place, not getting the right service, and them and their relatives are not having the quality of death that we believe they should be having.
All right, thank you. Yep.
And this is for Michael Sobel House. I think one of our meetings you did say that the fundraising had been affected because of everything that's happened. Has that picked up now?
Simple answer is not really. In the last financial year, so our year end is 31st of March, we currently, in management accounts, which is about in fact the audit starts this week, show that we had a loss of £80,000. The income was substantially down, but our costs were substantially down because we were only paying for the day centre, 10 members of staff, etc. And therefore, it's not too bad. In the last couple of weeks alone, we've actually been notified of some legacies, and our legacy income was really quite low. But in the last couple of weeks alone, that's been £123,000. So we still have a fantastic level of support from the people that are out there. But we need to get some movement. We've talked about it, I know, Chairman and Councillor, but we do need to get the movement because we cannot afford, and indeed Harlington can't afford for us not to afford, to lose that support. We're fairly confident that if we can get the movement going and our public can believe us, right, that we'll be able to actually get that income back up. We've continued to recruit. We're about to add an additional person into our fundraising. As Steve has said, we're actually jointly fundraising. We're finding a way of actually putting minds together to come up with new ideas, etc. Our largest event of the year is in September, which is Ladies in the Night Walk. It's a bit early to tell whether that's going to be well supported. I'd like to think that after some of the things we've talked about tonight, it might be better supported than it would have been before. But we do need to get on with it. And I know I keep repeating myself, but it's urgent. It's not just urgent for our funds. It's urgent for the people to trust us. So for argument's sake, one of the things that's disappointed me most is that because of this delay with these East and North Herts CCG now being the coordinating CCG, and I was first told that on the 1st of May, and here we are on the 9th of July, and the meeting's on the 11th, right? But anyway, so one of the things that's happened is that we've lost or Eastern North Hearts Trust have lost, and therefore the NHS and therefore Hospice Care has lost members of staff. This week we lose a senior staff nurse who was excellent at Hospice Care and has worked for the day centre and indeed the IPU for many, many years. That's sad, and that's another reason we have to get on with it. So I hope that answers you, and lets me also express view, Chairman.
All right, thank you. Councillor Maloney.
Very quickly. Thank you. I'm Councillor Ali Malani. I have a very, very quick question in regards to access to the building. Largely because, as Michael pointed out, that the charity would need to do its own costings as to what refurbishments need to be done, which I would say is very, very prudent, given that we've heard everything from millions of pounds that need to be spent to very, very little. So, given that on Thursday we're hoping that everybody can get on the same page, and that you're estimating about 6 weeks worth of works that need to be done, and knowing that building works can range and can be unexpected, my question to here would be, and treat me as a naive person that doesn't understand or has a lot of impatience towards bureaucracy and legal guidance and all that sort of stuff. What are the barriers to stop access to the building? So no work being done, but access to the building so Michael Sobel Hospice can get the costings that they need so that we can move at pace once all of the paperwork has been done. How can we get them into the building to do those costings?
Unfortunately, that's something that East North Hearts would have to grant. Under the landlord and tenant obligations, they enjoy what is known as quiet enjoyment. So as a landlord, we cannot simply be trespassing on premises which is formally been handed over for a tenant's use.
Sure, but let's assume they do that on Thursday. Let's assume they give you that green light on Thursday. There's nothing on your end that will stop Michael Sobel going in and doing their costings, though.
We'd be happy to support them.
Thank you.
Michael.
One thing I'll say in support of Eastern North Hearts Trust is that of recent occasions when we have wanted access, we've arranged it through Kelly McGovern and it's been made available. So I think that together we should be able to get access to get the full costings put in place. So I think that can happen. It's getting the full access to do the work that's been worrying us. To do the work, not to cost the work. Yeah.
Right. If it comes, there's two things before we finish on this topic. One is that we said last time, and everybody agreed, that everybody seems to think that the building, Michael Sobel House as it stands, has probably got somewhere in the region of 18 months, 2 years, something like that, in terms of useful life. And we also said that we would that time period would be very usefully used and quickly used to look at long-term arrangements, which might be exactly where they are or might be a little bit further away or what. But that's for certain, because we all know that the building itself has had a very happy and long life, but it's coming towards the end of it. And that work needs to be done, and it can't be done until this all happens. And the whole idea of getting it reopened and re-established was to be able to take that forward and then have the traction with supporters to make more money, hopefully, in order to find somewhere that's even better and will last another 50 years or whatever or more. So we know what the reality is as far as that's concerned, and maybe there was talk about swapping buildings and looking at alternatives on the same site, perhaps, who knows. So that's got to be considered in the background. Also, what's got to be considered in the background is the overall way in which end-of-life care is delivered and what people want, because different people want different things. But for certain, one of those things within end-of-life care that people do want is in hospice inpatient care, because it's different. I know I'm telling people what they know, but it's different to any other sort of care, and we know that. That's why wards 10 and 11 are hopelessly inadequate, just wrong for this sort of care. So we need to keep those two things in mind, I think, importantly. But if it comes to it, it seems to me that because we seem to get more done sitting round tables talking to each other and getting more agreement in that way, that if we don't get what we would hope on Thursday at this meeting, then efforts will be made to get all the parties together and just to hammer it out, and to literally have someone stood in the middle saying, right, why can't we do this? Why and get an agreement at the end of that. How we sort that out, and whether it's even for us to do, but how we sort that out, we'll have a think about. But if that's what it takes, that's what we'll do. All right. As I say, I think that's pretty much as far as we can take things. Thank you very much, everybody, for contributing. I hope we've given everybody a bit more hope and are aiming to it. And I look forward to meeting everybody again at the grand opening whenever it is. Thank you very much, everybody.
Don't need to be here for the second part. Go.
We'll take a 5-minute break so that everybody who doesn't need to be here for the next bit, which is all the quality accounts from the various trusts, can come along. Update. Have we got all our... Okay. All right. Thank you very much, everybody. Almost on time. That was quite good. Right. So we're going to go with the updates now. And where are we? Item 6, health updates. So we will start. And I think realistically we can only really be 15 minutes for each one, because otherwise we'll overrun horribly, and we've got 7 to get through. So we'll start with CNWL and Kim.
Oh yeah, sorry, I'm so loud. I think I don't need that very often. So I'm Kim Cox. I'm actually the Borough Director for Hillingdon for CNWL for mental health. But obviously, because I am the only director that's in Hillingdon all the time, I tend to come and present overview. I've sent a report through. I've sent it through on a PowerPoint, but I'm not going to go through it on a line-by-line basis. You'll be pleased to hear. I'm just going to go through and pick out some of the highlights and the things that you would like to know about, some of the positive things that are going on. I've included, I'm assuming you've all got this, page 55, yeah. I've included some of the CAMS waiting times there for you. It is me that pulls this report together generally. And as you can see, the CAMS waiting times are fairly stable now, but there's still some work ongoing about sustaining the 18-week referral to assessment target. But I think the CAMS director has been before and spoken to you about how these cases are prioritised, and that anybody that's potentially risky is picked up. And there has been, I'm looking to Caroline here because she can help me, support me with this one, but there has been a huge improvement over the last 2 years, and there has certainly been additional investment into the CAMS services, and the CAMS patients, children, are getting a much better service, but there's still a way to go. I'm not going to pretend that's perfect at the moment. Moving over the page, I included the eating disorder services because I don't think it was something that I'd brought to you before, in as much as that we do have a community eating disorder service in Hillingdon. We do have quite a few young people with an eating disorder. Most of them are in the younger age group. They get consistently good performance targets, and we do have an inpatient service in central London. We don't often have inpatients from Hillingdon in there, but it does happen on occasion. It's generally only one young person or one person in our eating disorder service in central London at any one time. If you ever wanted any more real detail on any of these services, I could certainly bring and do just a specific one as we go through. Children's services, I'm not going to go through all that. They've wanted to share with you all the great things that they're doing. I'm assuming that you've heard about our QI projects at the last meeting that we were at, and how this is the trust has really taken off with our QI projects. And there are 3 in QI projects that they're doing specifically within the children's services about improving the sleep management, reducing the waiting times, and increasing the number of occupational therapy contacts are ongoing at the moment. And so far the feedback we've had from those is that they're proving really positive, especially about increasing the number of occupational therapy contacts, which can only be good. I've included a little update there on the Hillingdon Healthcare Partners. I think one of the most positive things that's coming from the Hillingdon Healthcare Partners, obviously not just our collaborations with Hillingdon for All, the GP Confederation, and also with Hillingdon Hospital, but it's also that this is starting to gather a bit more of a pace now, and we're starting to include mental health in that. And one of the questions that was asked was, I'll talk about it, about the is that we have actually been fortunate enough to bid for some additional funding as part of the mental health 10-year plan and the palliative scheme. And one of those things that we're doing is looking at getting our physical health care nurses, which is the best way to explain it, is some advanced mental health care training. So the idea is that people, when they're visited, I don't know, by maybe a district nurse who's come to change a wound and they seem a bit down, that district nurse won't have to then call in the mental health services to do an assessment. They'll be able to do the bases there and then. So I think that's going to be a work in progress probably over the next year, 18 months, but I'll certainly keep you updated on that as we go through. The adult services, I think one of the really successful things there was the Your Lifeline, the 24/7. This is about successfully keeping people at home who are dying, actually. It's palliative care service. Previously, I think I did come and present this earlier, where people would generally phone for an ambulance if they were in crisis at night, if they were offering palliative care, hospice at home type pieces of work. We now have this lifeline, and the figures that are coming from that are proving absolutely phenomenal, actually. I think they managed to keep or help to keep up to sort of 60 people at home in a 6-month period who previously may have ended up in hospital, may have ended up calling an ambulance or calling the GP urgent services out. So there'll probably be an annual review for that, which I'll certainly share if you want it as we go through. Please stop me and ask me any questions. I know I talk really quickly, so it's all in there. That's it. Mental health services. So one of the really exciting things, as I alluded to, was that we have commenced the SIM project, and the SIM project stands for, it's a bit fluffy, but it stands for Serenity Integrated Mentoring. And what that basically means is that we now have, and we're one of the first in London, we now have a full-time police officer and a full-time or full-time post mental health nurse working with the people who present to the police and the mental health services most frequently. They've got a caseload of about 20 people, and it's a really collaborative piece of work. It's probably I've just spent a whole afternoon there, but it's certainly supported by the Met Police, certainly supported by our local colleagues, both from a social care and a health perspective. And we've hit the ground running with that one, actually. We had an evaluation from the national leader of that today, and he said it's all really positive. We've been very careful who we've picked to work in that service, and the service users are already giving us, or patients, whatever you want to call them, are giving us really positive feedback about it. We're only 3 months in with this project, and the aim of the project is that over the course of, maybe it will take sort of a year to 2 years, that we see this big reduction in this number of people being picked up by the police on the streets and then having to be conveyed to a mental health unit, health-based place of safety, and we can look at those behavioural elements of why people are turning up with us. There's a big bit there about we are bidding for some of the additional funding around the palliative esteem to care for people with a mental health problem. We have a lot of change plans in place. We're just waiting to see if our bid is successful. I think we'll know. Should be Friday, isn't it? Yeah, Friday. We've worked on this together with our mental health commissioners from the CCG. We're looking to expand our mental health offer, if you like, into the primary care services with more mental health nurses in GP surgeries, able to offer mental health interventions, do a little bit of screening, able to signpost people, and also looking to offer, hopefully if we can get this through, some form of service for people with a personality disorder. We're also looking, and we are doing this jointly, not all of this funding will be coming to CNWL, but we're looking to set up things like crisis cafes, maybe a little bit of street triage, and there's some housing corporations, I don't know if that's the right word for them, setting up homeless hospital homeless shelter in the borough. I hope in November they will be doing that. And do you remember, I think I came maybe a year ago, spoke to you about the amount of people that we have stuck in hospital who sometimes don't have recourse to public funds, aren't able to move on, and they've set that up, and that will all be funded through housing benefit as it would normally, and they get volunteers and peer support workers in to help people navigate their way through the systems to get in a home. So we're quite excited about that. I've put in there a bit in there about Arch, and Arch is our substance misuse services, and one of the really good things is that they are Arch. I don't know what it stands for actually, but it is our substance misuse services. I think they called it Arch because it's a collaboration of not just CNWL services, but also some of the third sector organisations that are able to provide support for people with a substance misuse. But one of the really brilliant things that they've done is that they have actually started doing fibro scanning, which is liver scanning, really, sort of on the spot there and then. They've trained the staff up to use the equipment, and that, again, saves people having to go to the GP and go for things. And if you can catch people there and then, if they've got a problem, able to offer some reassurance. So they're doing some really good work around that. And they are offering a health passport, which is for alcohol misuse clients in the borough. And this will be things like making sure they'll have their health passport, check-in, their liver check-in, and it's something that the patients, the service users can carry on them all the time. So if they turn up at their GP, even though that would be on records, it might mean that they can say, well, actually, I saw my worker yesterday, so that kind of, and when their next appointments are. So they're also they've seen a big increase in people with street homelessness attending the services for substance misuse recently. So they're trying to look at doing a little bit more outreach work. I understand. I can get more detail on this. You wouldn't necessarily know. Not detail, yeah. So the street triage for them, that they are seeing more of that. I also included a bit because I think, so I don't know if you know, but CNWL also provide the healthcare services, or some of the healthcare services at the Immigration Detention Centre. And I know that in the past people have asked me, well, what do you actually do out there? And I know, as I said, they provide like a GP service, and they have like a small hospital there. And that they've sent me a slide just to say what they have been doing. They have been inspected by the CQC and were required to make some improvements, and these are the things that they have been doing. And if you did want to talk to any of them, I could certainly get them to come along. And then lastly as well, another service which we provide here is an offender care liaison and diversion service, and this is basically mental health nurses able to offer assessment at the Magistrates Court, Heathrow Custody and Hillingdon Youth Offending. And you'll see that that they have seen the number of total arrests drop from people that they have intervened with. But this is really, if somebody attended court and they were thought to have a mental health problem, they would be diverted away from the criminal justice system and into the mental health system, or the social care, educational training, whatever it was that they required. And they are there. If court's open, they're there, and they do work. They work. I think they work 8 till 8. So if somebody is brought into custody at 8 o'clock in the evening, they generally have to wait until the morning. But I know that they see as many people as we see from the generic mental health services through our A&E liaison service. So they are, in terms of assessments, that they are completing. And that's my lot.
Thank you very much. Councillor Arnold to start with.
Thank you, Chairman. My name is Councillor Arnold. You mentioned the SIM project that we were involved in. Can you explain the difference between that and the standard sort of Section 136 136 is?
So Section 136 is where the police will pick somebody up from the street and bring them to a health-based place of safety, which is in the Riverside Centre at Hillingdon Hospital. And it's a form of detention, really, where somebody will come and they will have an assessment in the first instance by a doctor, and then that might go on to mean that they need an assessment under the Mental Health Act, which is then two other doctors and an approved mental health professional may end up getting admitted to hospital, may end up being discharged with home treatment, may end up saying actually there's no mental disorder there at all. So the SIM project, what the SIM project is doing is it's a full-time police officer that's working within mental health services, and the way that they describe it is that some of our people who are picked up by the police and brought to the health-based place of safety under a Section 136 often are people in distress rather than people who have a mental illness. There is a very big difference. Are people who can see no other option other than either to commit an offence, who feel, the only way that I'm going to get a cup of tea and somebody to talk to is if I start carrying out either self-harming or harmful behaviour to others. And we've identified that sort of a third of people that come through, that the police bring into our Section 136, and the police are right to bring the people in. They're very few people that they bring in would I have been able to say, yeah, actually you should have just walked away and left them to it. They're never, in terms of options that they have available for them, they're very, very few at the moment, but we're looking to address some of that. So the SIM project, what they do is they offer sort of this intensive mentoring where they work they have what they call a blue intervention, which is the police, or a green intervention, which is health. So the green interventions will look at things like, are you taking your medication? Have you got enough support? Do we need to get you through housing? How do you feel? Do we need to get you some counselling? And whereas the blue interventions will be, well, actually, all that drug taking that you're doing is not good for you. How are we going to stop you doing that? It will be very much about your behaviour is not acceptable. We often get quite a lot of people causing, I don't want to say public nuisance isn't the right word, but carrying out antisocial behaviour. And they're doing that jointly. And there's been some national work done on this. It was started on the Isle of Wight, actually, which is great. I have more of a captive audience there, but it was started on the Isle of Wight by an ex-police officer, and they've had some really, really good effects in helping to maintain these people in the community without them having to come to hospital. They turn up at A&E. They ambulances end up picking people up and bringing them in. So it's quite a different project. It's quite a positive one.
All right, thank you, Councillor Manala.
Thank you, Chair. So in the Hillingdon CAMS bit, there's mention about the fact that the capacity of 3 CBT therapists is being reduced.
Yes.
So my question, I guess, was what does this look like in the patient journey? How does that impact waiting times and all that kind of stuff? And is there anything being done to plug that gap if the funding is going to dry up in a more creative way or in a different way?
Yes. Yes and yes, the answer to that. So the funding was put in place with us because we had such a backlog, and a lot of that backlog has now been cleared. The risks are, of course, that backlog starts to build up again. But the team are looking to work there's been additional funding gone into the core services now as well. So the pathway for people when they come through the CAMS service is quite different, and the offer of, so for example, in the past you would have been on the waiting list and you would have had to wait to see a specialist for an assessment, whereas what they're trying to do now, I believe, I'm not the expert in CAMS, but what they're trying to do now is they'll make an initial contact with that person, see how great their needs are, prioritise their needs, and in some cases can actually signpost people to alternative services. I'm looking to Caroline commissions, so that was it. So the funding was only temporary. We knew it was only temporary. We'd planned for it to be only temporary, and we're looking to be a little bit more creative around what we can do about that service. And it will be really closely monitored in terms of that from both a contracting perspective and also a quality perspective.
All right, thank you. Just a couple of things finally from last time, which I think probably are more to take away and come back to us on. We talked about getting some further detail on the progress being made in regard to the Zero Suicide Alliance?
Well, actually, that's quite timely because so the Zero Suicide Alliance, I mean, in terms of the progress that's being made with that, I will have to update you on, but I was going to inform you this evening that C&W on mental health, we've been being filmed since before Christmas for a documentary about, specifically around men who wanted to take their own life, and this documentary is being screened on the 12th of September. On Channel 5, but you know, and so but it is about they've been filming mostly our home treatment team and the suicide work that we've been doing there. As a result of that, there's a progress. It's an hour and a half documentary, and there's another half an hour afterwards with so-called experts, and I'm one of them, which is why I said so-called. We've been interviewed to ask what we can do to help people with depression and what that means specifically for young men, and where we can signpost people. And it's I've seen the first cut of it. It's actually quite good, and we're hoping that you know the Zero Suicide Alliance training is rolling out far and wide. One of the options that we've got for helping our physical health nurses, especially when we talked about it, was getting them onto that training. You know, it is about asking the question, "How are you? How do you feel?" So.
Yeah. The other one, which Councillor Dennis, who couldn't be here this evening, raised was on the last occasion when you gave him a more detailed breakdown, was a breakdown of complaints 1819 about the nature of the complaint.
So
I think it was more
nature.
to do with
was it the theme of the complaints or the nature of the complaint? I wasn't here at that meeting, I'm afraid.
I think it was the nature of the complaints, really.
In terms of.
In terms of what they were about, or if there were common themes,
common themes. So can I get back to you on that one for next time? I'll send something through to you. And that is for the whole of the services C&W provide, or was that specifically about the adult physical health?
I think it was more to do with the adult physical side of things and mental health, but in regard to, but also concentrating obviously as ever on the Hillingdon aspect.
Oh, only the Hillingdon aspect. Yeah, that's fine. I will get that.
All right, thank you. And finally, and I didn't do this last time, and I should have done really. We were told that Maria O'Brien had been promoted, so she wouldn't be coming on. But I just wanted to put on record our grateful thanks to Maria over the years for providing a brilliant service to us from C&W. She's always been very good at engagement and giving us, full answers and fantastic service. And we wish her great success in her promoted career. And perhaps you'll take that back.
I will definitely take that back, and I will bring my new boss along to the next one.
Thank you very much. That's great. Thanks.
Okay, thank you.
We'll move on now to London Ambulance Service, and we're greatly delighted to see Desiree Papadopoulos here.
I'm not Michael Breen.
No, you're not. No, I knew you weren't Michael Breen. And I must ask you about possible cleric relatives you have later on. I mean, you may not be the same Papadopoulos family, but there can't be that many. Oh, is it? Oh, all right. Because one of your family members is the Dean of Salisbury, but there we go. Right. So what we tend to do, what we do is each of the trusts is allocated to either one or a pair of our councillors to specialise in, and as far as London Ambulance Service is concerned, it's Councillor Haranchi. So, we're delighted that you're here. So, if you'd like to sort of give us the sort of headlines from your update, which.
Yeah, you have to excuse me. Sort of handover from her. How's that?
Yeah.
So I will do my best, but please feel free to stop me if I'm waffling or I'm not telling you what you want to know. So what do you want? A bit of a headline on our sort of...
Headlines in terms of where you are across... I mean, there are common themes that we've had over the years in terms of the service. There are common themes in terms of the service, and I suspect, and looking at your report, that many of those are dealt with. But just a sort of update in terms of the issues that are of more concern as far as you're concerned.
Okay. Well, I suppose so. We've got a CQC inspection coming up. So obviously we're looking particularly at the quality we've improved from required improvement to a good standard, apart from caring where we received an outstanding standard. So we've sort of been focusing on that and developing things. I suppose what I should probably talk about is things like the pioneering services that we're running. So that's integrated urgent care. I'm sure you know, we run North East London's integrated urgent care and South East London's integrated urgent care 111 services. And then the other pioneering services will be maternity. So we've expanded our pool of midwives that we have in our service. We just used to have one consultant midwife. We now have 3 on the team. Mental health services. So we've done a pilot in South East London of a paramedic and mental health nurse response car that obviously are targeted being sent to mental health patients that are in crisis. The figures that I've seen are really positive, so a sort of 70% referral, no conveyance, compared to sending a normal paramedic response, which is generally around a sort of 30% referral to a team as opposed to going to the emergency department. So that's really positive, and hopefully from that trial they'll expand it pan-London as opposed to just currently in the South East. Falls is one of our other pioneer services. So we have, so Hillingdon has a Falls vehicle that specifically is targeted to patients who've fallen over. Obviously trying to reduce the amount of time that the patients are on the floor, and then also trying to avoid ED admission and do referrals for home treatment to, stop falls clinics, that sort of thing. And then our last pioneer service is end-of-life care. So we've just recruited in each of our groups. So in the Northwest we have 5 groups, and they all have an end-of-life care volunteer, so it'll be a paramedic or an EMT that will undertake sort of CPD events in the sector for the staff. So that might be asking a consultant from a palliative team to come along and speak, promoting the use of CMC through our iPads, that sort of thing.
Just on that last bit,
yeah.
Before I hand over to Councillor Angie, end-of-life care, how does that fit with ambulance service in the sense of your priorities and going in that direction?
So it's very high on our agenda. So obviously CMC, Coordinate My Care Service, the London Ambulance Service has been engaged with quite a few years. Patients that have created a record either with their GP or with a palliative team are stored on the system. We can notify our staff through their mobile data terminals that the patient has a record when they're en route to the patient, and they can then view the record on their iPad, and it will have things about what the patient's wishes are, where they want to be treated, whether they want to be resuscitated, what sort of drug regime they have, anticipatory meds, which teams are known to them. Our paramedics, can then call out the team and say, this is the situation, get advice, decide whether ED is the most appropriate, remain at home, refer for services to visit at home and help the patient, that sort of thing.
And I suppose with because before you came, we were talking about hospice care, but with the general overview of end-of-life care as to what people want, and we're hearing that not overwhelmingly necessarily, but a lot of people would prefer to be cared for at home.
Absolutely.
You'd be called out because things are getting worse, or? Yeah,
I think from personal experience, in a lot of cases, families are a little bit panicked. They have a dying relative, they're not prepared for it necessarily. It is quite scary to watch, and they often call us for a bit of reassurance, maybe to administer some drugs. But I think in a lot of cases, it's for advice, reassurance, some support. And we can obviously provide that in the emergency setting, but it's what we then do following that, when we go there at 2 o'clock in the morning and we give them some advice and give them some support, but then it's that follow-on so that a team arrive at, 7, 8 a.m. to assist the family further, as opposed to us just leaving and that sort of being the end of it.
And Caroline, is that something that's factored in to this whole debate about what people want?
Yeah, so Kim talked earlier about the Your Lifeline service. The other sort of part that we've commissioned is something called the Palliative Overnight Nursing Service. So in Hillingdon, there's actually a nursing service that can go out overnight, so you don't necessarily have to wait until the morning. So we are always really looking at ways to support people to receive the best quality care they can in their own home, if that's their choice.
Okay, look, I think at this point, if I bring in Councillor Harangi to ask her questions, that would be quite useful.
for the update. In the past, I know we've normally received a draft quality accounts, just so we're able to discuss and contribute, and some of our contributions have been taken, but this time we received a final and a published one, and it was received at quite late notice.
Okay.
Do you know why?
I'll be honest, I don't. I'm sorry. As I say, I was on leave, so I can certainly go back to Natasha, who will be at the next meeting, and ask her why that sort of happened on this occasion. So normally you would get the draft and you'd be able to comment on it prior to it going to completion?
Yeah.
Okay. Yeah, I'm sorry, all I can do is take it back and...
Thank you.
Right?
Okay. Okay to carry on, Chairman? So just a few questions about, I guess, waiting times and handover times. I know in the document, the quality accounts, it said something about wanting to reduce it from 17 to 15 minutes by April 2020. Where are you with it at the moment, and what are the numbers?
So the northwest sector, as regards to the London Ambulance Service, handover to green for non-blue call patients is at the top of all the 5 sectors. So north central, north east, south east, south west, and then there's north west. Where we're struggling is with our blue call patients, so patients that we're pre-alerting into hospital, and we're currently sitting at around the sort of 16.5-minute mark. So that's what we're trying to reduce. So I think really it's about educating our staff, the hospitals likewise, that the has-been system's being used appropriately, and that it's not being overridden because it's a blue call patient. And that sort of thing. So yeah, we're doing very well with non-blue patients, where we've got more work to do with our blue call patients. And aside from the re-education, are there any other solutions? Because I know in the document it mentioned that you were looking to implement some solutions and technology at the beginning of the year, and how, if you've done anything and how that's going. I mean, I'm not aware of that. So we meet our staff regularly for a sort of performance review, and handover to green is one of those. So it is something that's constantly on the radar and that staff are constantly being measured against. And obviously it's one of the metrics, along with how long they're on scene for, that we measure. You know, obviously trying to reduce their on scene times. But I'm sorry, I'd have to go back and find out what sort of technology it was that they were looking into. I can certainly find out. Sorry.
That's okay. I know you were dropped in.
You'll have to let me off because it's my first time here.
Also, I know historically there's been issues in terms of recruitment and retention.
Yeah.
How's that going at the moment?
So yes, Northwest particularly, and we don't really know why, has had a real recruitment and retention problem. We recruited quite a lot of Australians a few years ago. Most of those are now returning home. They've done their time in London. They've had the experience of working in London. It's set them up really well to go back to Australia and work in Australian Ambulance Service. So unfortunately, we're now seeing the pains of that recruitment. However, we have just opened an operational placement centre at Hanwell, which is really great because we only had one at Kenton previously in our sector. That's currently got about 30 crews working out of it. And I think the programme is for about 300 staff over the next 12 months. A percentage of which will go through Hanwell. The hope is that by training in the sector, they will remain in the sector, whereas previously we've had staff that have trained in, say, South West at New Malden, and then as soon as they're posted, they put a request in to go back to New Malden because, you know, it's where they trained, it's where they've become familiar to. So hopefully this will challenge that and tackle that, and they'll stay in the sector once they've trained there. So yes, in the next 12 to 18 months, we're hoping it's going to improve significantly because it has been a real problem for us in the Northwest.
Would be good to get an update on that at one of our future meetings. Yeah. I've got two more actually. You mentioned the pilots at the mental health service where there's a mental health nurse, and I know you mentioned that it's going well.
Yeah.
Do you have any timescales on it being rolled out to other parts of London?
I don't, I'm afraid. I only have that they did a 6-month pilot, I believe it was, and I think they've only just done the evaluation of the...
I think it started in November.
So it says mental health response car service to be rolled out across a minimum of the South East sector during 2019-20. But that's all it says. That was in that quality report that you were sent. And there's some figures there about how they've performed against our normal paramedic response. So again, I'm sorry, I'd have to go back and inquire. Sorry, I'm not doing very well, am I?
Very last question from me. What pressures are you concerned about? I mean, I guess more in terms of what would be useful to discuss or to bring to this forum for us to discuss at a future meeting.
I mean, our Category 1 patient wait times are good and are within the national standard. Our Category 2 has been challenging. In fairness, it's been challenging across the whole of London, although nationally we are one of the sort of best performing ambulance services for patient wait times.
Are you able to explain the difference between the...
So a Category 1 patient, which would be classed as your sort of highest priority critical patient, is a 7-minute response. Hillingdon CCG currently sits at 6 minutes and 43 seconds response, 6-minute 44-second response, so within the national standard. Category 2 patients, so you're sort of sick but not critically sort of life-threatening sick, as it were, and it's a very large proportion of patients, unfortunately. It's an 18-minute mean response, and Hillingdon CCG is currently sitting year to date at 24 minutes and 8 seconds. But as I say, it's a metric that across the entire service we are struggling with, and I think it's predominantly around the volume of patients, and in Hillingdon it's the geographical size because it's a very large borough, and where the hospitals are sited, it means that the crew may have a potentially long run back from the hospital to the patient.
It will be the last one.
Yeah, right.
And do you get very many people, I guess, who call the ambulance service and maybe the ambulance service isn't the right service for them? And
absolutely.
And is that something that's on the increase or what's being
I mean, this is what's really challenging for us. Our call handlers, our 999 call handlers in our control rooms are not clinically trained. They very strictly follow a pro forma. So if I say I can't breathe, despite the fact that I'm talking very calmly and clearly can breathe, they will take that as gospel. They can't question it. Unfortunately, that does mean that we probably do have ambulances responding to patients that don't necessarily need an ambulance response. What we need to then at that point do is to try and refer them to the most appropriate pathway, so not taking them to the emergency department, potentially not referring them at all, but assessing them or referring them to the most appropriate pathway and not taking them to the ED. So the first part of a 999 call or a 999 journey is very challenging because the volume of calls that we take and the fact that our staff, they're quite young, they're not clinical. It's a very stressful job, as I'm sure you can imagine. They get a lot of abuse. So yes, we obviously do send resources to patients. But, on the flip side of that, sometimes we're going to patients that on the sort of surface look like they don't require an ambulance, and then you get there and they're actually really very sick. So it's a bit of a balancing act.
Thanks. Just on that last point, it was just to clarify an understanding. So there's obviously the 111 service, and the 111 service can direct through to 999. Yeah. My understanding was that although previously it couldn't, that 999 now can redirect back to can direct to 111.
Yeah, so if we take a 999 call and it's triaged as a sort of low priority category 5, it's referred to the 111 service. My understanding from our sector engagement manager is that we are doing some work with 111 because we're getting quite a lot of 111 referrals from North West London. And I think it's partly to do with around GPs or something, but we're trying to do some work there to try and reduce the number of 111 referrals we get into the 999 service.
Well, I think we had understood, and maybe I may be misremembering this, that there was some sort of move to have more, because of the cost implications of sending ambulances full crew to somebody who frankly doesn't need it. Yeah. Even if they think they do. Yeah. I think we had understood at some stage that there was a move for better or more triage on the 999 calls.
Yeah, so we do have clinicians in our control room, and some of the calls they can ring back and do a sort of enhanced clinical assessment. Yeah. Obviously they're clinicians, they're paramedics only, and I used to do it. You have a lot more free rein than a 999 call handler does. I can ask questions, I can question a patient and say, well, you say that you can't breathe, but you're talking nice and clearly, you're talking in full sentences, and they can then refer patients to another service, not just 111. They can arrange a GP appointment for that patient, or they can send them in a taxi down to the GP surgery, that sort of thing. So there is that additional triage that we have in our control room.
I mean, is it feasible to, bearing in mind the cost of sending an ambulance and a crew or a car, whatever it is, against having better clinician-based callers, responders on the phone?
Yeah.
I mean, I know it's not, it may not be the highest grade in the...
Obviously it's a lot cheaper.
Yeah.
I think, if I'm really honest, the difficulty is paramedics like myself didn't join to sit in the control room on a telephone. So we find that we get some of them to do it for sort of 6 months as a temporary secondment type thing, and then they want to go back to being on an ambulance. So recruitment in that role, because I used to work in it, is quite tricky, because it's just not why I became a paramedic. It's really good experience. It enhances their clinical skills massively, because it's very hard to do it on the telephone compared to face-to-face. But yeah, it's not really, most of them aren't going to do it for years on end. They want to do it as a temporary thing.
I'm just thinking about the relative cost.
Yeah.
Of because it's a lot, isn't it, of going...
Oh, yeah, and in an hour I could probably speak to 5 or 6 patients on the telephone. On an ambulance, in an hour I can probably see one. By the time I've got there, even on blue lights, done my assessment, maybe conveyed them, that's an hour. So, yeah, it's a lot,
okay, thank
more
you.
efficient. Thanks.
That's very helpful. We do very much appreciate London Ambulance Service coming to us because we do, because there's always a lot to talk about, and the timing issue of the report's already been raised, but that's something that you can go away and come back to. But we've over the years we've had quite a lot of individual subjects that we've picked up on this committee and made reports on and hopefully helped with. So it's a good relationship. So we're very grateful to you. Thank you very much.
Good,
all right.
thanks.
Okay. Sorry? My microphone is now on. Right, we shall move on now to, where should we go? Royal Brompton and Harefield. So, Piers, welcome.
Thank you, Chairman. I'm going to touch on 4 topics briefly, and my apologies for not providing you with a presentation, but this will very much be highlights, and so I very much do welcome questions. Firstly, just to recap on the topic, when Nick and I attended the last meeting of the committee, we gave you an update along with NHS England on our collaboration with King's Health Partners, which in a nutshell would see Royal Brompton Hospital moving all its services and indeed its building to build a new combined tertiary cardiothoracic and respiratory centre at the Guy's and Thomas's campus, along with those equivalent services of King's College Hospital and Guy's and St Thomas's. That's 8 to 10 years away, and as you heard last time, NHS England are taking, shall we put it benevolently, a very active interest in it. We're now drawing breath and waiting for them to decide on how and when they wish to consult about that movement. This is giving us the time to start progressing some of the, shall we call it, grassroots collaborations, so getting combined MDT, multidisciplinary team meetings for particular services, for not just congenital heart disease, but also for respiratory diseases as well. We've got a passport in place which enables any one of our clinical staff literally with an email from their particular supervisor, enables them straight away to go and work in an equivalent service in either of King's College Hospital or Guy's and St Thomas's, and the same applies the other way. So we still think this is very much the right thing for the future for Royal Brompton. Harefield will certainly benefit from this because we will not be able to build or afford to build a centre that can accommodate all of Brompton's, Guy's and Thomas's and King's services there in one building, and I think you will see a redistribution of some of the services or some of the volumes of the services to Harefield. If I can now move on to what we're doing internally, and I wanted to touch first on our, we call it Project Darwin, our productivity project. About 5 years ago, we as a trust made a modest surplus of about 2 to 3 million. We then lost a whole lot of specialist service top-ups and also some research funding, and literally overnight ended up in a sort of ongoing structural deficit position of somewhere around 20 to 25 million. We've been addressing this through a productivity program called Darwin, If I can tell you just a few tidbits from how it's working out at Harefield. We have four theatres there, 3 of which are for cardiac surgery. Typically for a cardiac theatre, you try and do 2 cases a day, but due to complexity of some of the cases and also the way the case turns out, sometimes you can only do 1. However, all too often, through poor scheduling and inefficiencies, what should be a 2-case day ends up as a 1-case day. So in the past, we've been averaging about 3.1 cardiac cases in these 3 cardiac theatres. Very much as a result of this productivity program, we're now up to about 3.7. We reckon we can get to somewhere around 4.2, 4.3. So it will be about a 33% increase in productivity. Nearly all of that, as well as giving a way better patient experience, most of that 33% benefit will go to the Trust's bottom line. Yes, there'll be some additional consumables costs associated with the increased number of operations, but the fixed cost will therefore be spread over more activity, which is great. Similarly, one of the things that we used to, when patients come in for surgery, in the past only something like 15% came in on the day of surgery, were admitted for the day of surgery. Again, through better planning, through the use of taxis to pick up patients first thing in the morning, we've gone and increased that percentage from 15% to around about 70%. And the remarkable thing about it was done in literally 6 months through one very determined theatre nurse who got fed up of the inefficiencies and took it upon herself to, as she put it, sort it out and sort the surgeons out. That not just doesn't mean that we save a bed a night, £300 bed. More to the point, it means that the poor patient who is contemplating next day having heart surgery is spending the night with their loved ones rather than by themselves in a hospital bed. So those are definitely some of the highlights of that Darwin programme. On the pathway side of things, in terms of our RTT, although we're above the 92% level, in other words, 92% of all our elective referrals get seen within 18 weeks, there are some subspecialties which I know North West London CCGs are interested in, particularly around cardiac surgery, where the percentage is down near 50%. What we are hoping to do is address some of that through, again, our Darwin project. Some of it is down to inefficiencies, poor management of the individual surgeons' wait lists. So we've got definitely some more work to do there, and also on getting to grips with some of the data behind our cancer pathways. Recruitment-wise, in terms of staffing, we remain okay. We've got, again, at Harefield, quite an innovative, in terms of nurse recruitment, recruitment scheme where we've developed a rotation for Band 5 nurses coming out of training. And instead of putting them straight into cardiac surgery or into transplant, we enable them to rotate through about 4 different areas. And it's probably not rocket science, but we've seen our ability to fill hitherto quite difficult posts to recruit to Band 5. We've seen a much better fill rate over the last 2 to 3 years.
Because they know they're going to get a wider experience.
Because they're going to get a wider experience, because they get the choice of which colleagues the place where they feel most comfortable with. Maybe it's a particular group of colleagues, whatever. There is a choice, an element of choice, which has worked very well. Back at Brompton, our PICU nurses remain a very, very precious commodity, but although the vacancy rate remains about 15%, we are continuing to fill it. A threat, however, for Brompton side would be the arrival of the Cleveland Clinic, which is setting up shop in central London in about 2 years' time. They will be recruiting aggressively for nurses and for technicians, and especially technicians like cardiac physiologists, radiographers, and so forth are already rare as hen's teeth and will become even rarer. So that is a threat that we will have to get our minds around.
Sorry, who are the Cleveland Clinic?
Cleveland Clinic are a huge American hospital, multi-specialty hospital based in Cleveland, Ohio, who have very successfully built up an international practice of patients from the Middle East traveling, very wealthy Saudis and so forth, traveling to America for their surgery. They are a very good hospital. They see London as a market where, because an affluent market where they can, by recruiting local NHS staff, certainly the consultants, the surgeons and the anaesthetists, they can use some of their, as it were, their Saturdays, Sundays, some of their evening slots, time slots to come and operate at those hospitals. What they're doing too is, unusually for a private hospital, they are aggressively targeting our intensivists, so the people who staff the intensive care units. That is more of a threat, because one of the ways in which we've distinguished ourselves from other private hospitals in the past has been that nobody is able to give the proper follow-up care, especially post-operatively, that we can do. So in relation to complex heart surgery, if you're a surgeon, you don't want to do your complex case at a private hospital. You would rather do it, a private case, at an NHS hospital, because you have the backing of a really, really good intensive care unit. This is why the Cleveland, where their approach is going to be actively recruiting NHS intensivists and wooing them away from their NHS contracts, which is a worry. Whether they can do so or not remains to be seen, but that is very definitely a threat. The last thing I wanted to touch on is just quite an exciting new model of care for our cystic fibrosis patients. We've developed or prototyped in league with a company called MeadowPad, who are a digital app, clinical app development company. We've developed a platform whereby a cystic fibrosis patient, many of whom are quite young, tech-savvy, but also fiercely independent-minded and don't want to have their disease to define their lives, are fed up of having to travel into hospital for checkups or when they get exacerbations because we haven't picked up in time when their condition deteriorates. And this platform is basically going to be accessible on their phone, on their tablet, and will enable them through scales, a pulse oximeter, blood pressure cuff, and then a spirometer. The data from those various pieces of kit will come through broadband, the standard Wi-Fi, internet, or whatever, internet environment, and will be beamed or carried down to a platform operated by this tech company, and then that data represented on the patient's mobile phone. We at the Brompton will get to see that data too, but we have to wait, and the way we've designed it, it's very much up to the patient to take the decision. I don't like the way my readings are looking on my, for example, my lung function, and then there's the ability to do a Skype clinic there and then with a nurse back at the Brompton. And what this, we hope, will do is primarily, first and foremost, mean that CF patients will have a much more independent life. They will take more responsibility for managing their care. Critically too, and if you're probably not familiar with the Brompton's facilities, the respiratory wing was opened in 1860 by Prince Albert. We can't expand it. It is not fit for 21st century healthcare, frankly, and we cannot fit all the patients we would like to see. By having this new platform, we will need to see less patients because we can see them remotely through the Skype platform, and they also will probably anticipate deteriorations in their condition, which will stop them having to be admitted for inpatients. So we've been developing this for about 2 years in close consultation with about 10 of our 600 patients, and we're about to move into actually building it and launching it. So that's really exciting. That's me.
And is that something that you'd be able to export to other areas?
That's a very fair question. Yes, it is, but we have to. It's not the potential for other respiratory diseases like severe asthma and for heart failure, other chronic conditions, is considerable. But we were at great pains to develop or design the model of care fairly slowly and taking a lot of feedback from patients, because each patient cohort is different. The devices are the same, so you will need a blood pressure cuff, you might need scales, weighing scales, and you might need a pulse oximeter, etc. But the way in which that platform works, the way in which the patients want to interact with the healthcare team at the other end could be entirely different. So it's interesting with CF, you normally think that patients want to have lots of information provided to them about their condition. Not CF patients. They're young, quite independent-minded. I know all about my condition. Don't give me boring videos. I know how I need to feel and what I should be aspiring to do. So that would be very different from what we think a heart failure population would want, who are typically 60, 70, 80 years old and so on.
Vino, the water is with Caroline, so if you want to, she's got a lot. She's prepared to share it with you, I don't know. All right. From what we saw last time, if you just touch the microphone, from what we saw last time, the attitude of NHS England in terms of whether it was your team or the away team, let's put it that way, it was still very much up in the air. Obviously, we think it should be your team. Do you get a sense of, have you picked up anything at all from them about decision making? Because I mean, all of this stuff that you've told us about, which is really good going forward issues, needs to be promoted against the backdrop of services going elsewhere.
I think officially we have heard nothing. Unofficially, because that's sadly how a lot of decision making is done. How frank can I be? Within those circles. Okay. Okay. Thank you very much. I think a lot of decision making happens at a level above the team that you saw a month ago. Our sense is that our proposition and certainly the support. I think the determination of all the clinicians involved, and that I think is a very critical factor, not just from Brompton, but also from Guy's and Thomas's and from King's College Hospital. The determination to say that actually this is a really good idea and this is a chance to make something transformational. It will be very difficult to do, but it is a worthy, lofty goal to aim for. That, I think, will be a decisive factor. I don't think NHS England or any of it, well, certainly we don't, but NHS England certainly won't want things like were they to try and split up our services, prospects of judicial reviews and all of that ever again, because we've been through that and we don't want to go there again, and they certainly don't. So I would hope they won't.
Possibly learning from the past may help, but
yeah. You
never know. All right, any other questions from anybody on this one? All right, thank you very much. It's very helpful, very grateful, thank you. Right, we will then go to THH for a quick romp through their update. Tahir.
I'm not sure that there are papers provided, are there, Chairman, for this? No, thank you. So I just want to put something in perspective. I'm quite happy to talk about the areas in which I'm more familiar with, but the longest standing member of the new management team is our chief executive, who is Sarah Tedford. She's now been at Hillingdon Hospital for some 6 months. We now have a new management team with appointments made respectively 4 months ago, 3 months ago, and as recent as a month ago. So the management board is now coming up to speed with a full complement of executive team members to support the way forward within Hillingdon Hospital, and that's really encouraging. We'll continue to move. We do still have a number of interim positions which we're hoping to fill relatively soon. The last 3 weeks of my time at Hillingdon Hospital has really been spent in trying to understand the current condition of the estate and the challenges that brings for not just continuation of service or continuity of service, but of course any future developments that we are looking for, both in terms of short, medium, and of course then an eye on the more longer term development of a modern hospital that provides the services fit for purpose within the Borough of Hillingdon. It's not surprising to note that some of those buildings, just at first glance, will give you an indication of how long they have been there and how they've organically grown to provide healthcare services. Clearly not fit for the modern day hospital services that we look to try and deliver our services from. Some of the buildings date back to 1907, and most of the buildings, the ward premises within Hillingdon site here, date to the post-war period as well. So again, very dilapidated, not fit for purpose accommodation. To add to the challenges that we have within Hillingdon is as the buildings continue to age and the lack of investment that has gone on over the past many years here, the system begins to fail or collapse around you. We now have huge challenges in relation to its infrastructure, the main compliance areas that we would look to ordinarily take for granted, the condition of our water, the condition of our heating and ventilation systems, and indeed, of course, right through to the way that the sewage drainage system is managed as well, all of which, over time, does require either replacement or modernisation. Hillingdon Hospital sites, both Mount Vernon and Hillingdon Hospital, have suffered from a lack of investment. Now, there is good news on the horizon somewhat. We have engaged with our partners at NHSI and NHSE, and the last few weeks, certainly with my focus on the more relevant and more serious matters, have been escalated to those parties. We have put forward an emergency capital request for funding to help address some of those issues, and that is now being seriously reviewed and we believe is now onward trajectory to the Department of Health and Social Care for final consideration. But that doesn't stop us doing what we need to do. We've not sat back. We are, dare I say, moving at risk to ensure that the appropriate procurements are in place, ready to go once appropriate funding from Centre is made available. It is a huge challenge to keep Hillingdon Estate operational, and it's testament to our staff for the services that they continue to provide from facilities which are not only not fit for purpose, but are indeed failing around them as well. They've become somewhat used to working in these conditions, and that's not good. Our patients, again, come to hospital not because they want to, it's because they have to. And this should be seen as a place of safety for them, a place where they feel they're going to get well. And that's a consideration to us, that we provide a facility that does that. Now, with that in mind, we have developed a way forward to look at where we go with the development of a new hospital. We've engaged the Good Governance Institute to look at what has gone before. It is not surprising that we have found or spoken to a consultant who has been speaking of a new hospital for the last 23 years. Yet we find very little evidence to see the outcomes of those discussions that have taken place with the relevant parties engaged in this. But that's a long time. Although indeed today they are still committed to delivering and assisting with a new hospital, which in itself is commendable. What we have done is, with the engagement of the Good Governance Institute, is we're looking at how we are structured, what has gone before, and what can we learn through that as well. They're also involved in the development of the strategic outline case, which will set about a clear pathway for the development of a new hospital. We are still undecided. As part of this process, which we are just about to embark on, is looking at whether this is a two-site or a one-site solution. Of course, we are looking at working with our partners such as Brunel and the various other SDPs, CCGs, CNWL, etc., etc. But of course, we need to go through a formal process. With the aid of NHSI, we've requested a gateway review, and this will look back at the processes that have gone before, so that we not only learn from them, but actually set about a clear objective moving forward. We'll continue to do that. Of course, there are going to be a number of options. Chairman, there will be a number of options which will be considered as part of any proposal moving forward, and we would hope that through engagement through committees like this, and in further engagement with the local authority, that we can start to realise some of those agendas, both in the short and medium term, as we keep on stream the hospital.
All right, thank you. Councillor Manali, and then I think Councillor Arnold.
Thank you, Chair. And Chair, I know you've only been here a month, but one of the things that we have felt, and certainly in my year on this committee, and more established members will say, is I have often felt that Hillingdon Hospital has sometimes hidden behind some of the estate's problems when there has been some leadership problems within the executive team, and I know that's a brand new executive team, so I'm hoping some of that can be taken forward. In that, obviously, we recognise the extreme challenges of the estate and the facilities that you have. That's not denied by anyone. But there have been other areas that have been highlighted in the CQC report, and often it's just the estates that's spoken about as the major challenge. So I'm hoping some of the leadership challenges that came out of the CQC report can be addressed. I have two main questions, and one thing that you won't know about, but I've asked before and we still haven't gotten. So I'll lead with that one. The first one being that we saw a report and heard a lot about the extension to the A&E of Hillingdon Hospital, but we asked for, when we were shown it, about what sort of HR strategy there was, or what sort of resources strategy beyond the estate there was to actually fill those spaces, so that we don't have 8 new beds but no one to man them, no nurses and no doctors to man them. So about whether there's a strategy to make sure that those spaces are filled. You won't have that on you now or know about that, but it'd be good to hear that. So
if I may, in parallel with this, we are indeed developing our strategies, our numerous strategies that support this. Part of that is our people and organisational development strategy. So HR, along with the information strategies, so the digital strategy, the estate strategy, will underpin what will be the clinical services strategy, of course. Unfortunately, I can't specifically answer your question around the ED. I can tell you it's now on plan to deliver towards the late part of this year, and we'll do all what we can to bring that forward as well.
Okay, thank you. My other question was, and you referenced it earlier, around your preparations for the winter rush. I know we struggled a lot last year with provisions at Hillingdon Hospital in the winter, specifically bed capacity limits, but also beyond that. Can you talk us through a little bit more about what you're doing in preparation for the winter?
So again, apologies, I'm not the right person to be speaking of the plans in terms of winter, and I'm happy to provide a note from those that are intimately involved in this. Certainly we are looking in terms of the preparedness for winter. We do that about this time each year anyway. From my own personal involvement, we're looking at providing suitable accommodation that will be available in the event that, and that is across both sides, that we need to flex our capacity to be able to deal with those pressures. I'm terribly sorry, I'm not really able to comment any further on that. I will also answer your earlier question about the fact that it may have been perceived that the estate was used as an excuse. I can assure you that that is not the case in this particular new management structure that we have. We don't intend to hide behind the estate. Quite the opposite. We have now a very transparent and open dialogue, not only about the estate, but the conditions or the recommendations that came out of the CQC report. We have formal work plans, workshops and committees in place to deal with those recommendations, and very good progress is made already to achieving some of those recommendations that came out of that report.
Okay, and very, very lastly, you'll be glad to know it's an estates question, the last one. So it'll be close to home. So often when we talk about estates, it's very difficult for me to grasp how big the problem is and how much progress needs to be made. Is there a sort of a bottom floor as to what is acceptable to NHSI and NHSE as to what a hospital standards would be? Because it would be good for us. I mean, you spoke about the emergency capital request. I'm not sure you can tell us how much your request has been or how far the hospital needs to go for it to meet your standards. But I would imagine, and again, this is coming not through expertise of the NHS, but logic and rationale, that there is a bottom floor in which a hospital can't go through in terms of its estate, in which intervention comes from NHSE and NHSI. Have we hit that? How far off with that are we? And also, this all seems like 3 questions. It's really one. How far off we are? How far in terms of the capital request are we from what you would expect to be a reasonable standard?
Okay. Thank you for the question. In relation to the actual estate, there are standards. There are general standards in relation to both the services and the buildings themselves. Those are born through technical memorandums or health building notes. They tell you what a facility should look like and the minimum requirements to deliver that service from. We fall below those. Although I would stress that they are largely guidance rather than standards, so that we have to absolutely adhere to, because we recognise that hospital buildings are different and have limitations in themselves. In relation to Hillingdon Hospital, it has a backlog. Now, that is what is an assessment of how much investment is required to try and improve the condition of the estate. We aim towards something which is called Condition B. Condition B is having an acceptable level of an environment that meets some of those standards I referred to earlier. Regrettably, no part of Hillingdon Hospital achieves Condition B standards. In fact, when we have run through what is called a six-facet survey to understand the condition of the estate, nothing but short of a redevelopment will suffice anymore. There comes a point where you have to stop investing or doing the Band-Aid type treatment because it's futile. The level of investment that the backlog for a hospital of this size, and it isn't the biggest hospital in London, is in excess of £200 million. And that's purely to put a Band-Aid and try and improve what you've got there. You have to put that in context against the limitations of the estate and its building, and indeed its infrastructure. So would you continue to invest in something that is so aged and so dilapidated and so out of date in that sense? So the challenge is absolutely huge. I think it's the biggest backlog in London, probably in the country, which gives you a perspective of the challenge that Hillingdon Hospital has. I myself have built many hospitals in London, some of the most groundbreaking hospitals in London, so I know the challenges of building new hospital estates, but I was yet to experience the challenges that Hillingdon Hospital has thrown at me in the last 3 weeks. It is huge. So from that standard, we are unfortunately very far away from meeting that Condition B standard, unfortunately. And all of the calculations and the equations, and whichever way you want to look at this, point to nothing but a replacement of it will suffice.
All right, thank you. I think it might be worth us as a committee considering having a dedicated meeting to I mean, it's our hospital, it's our borough hospital, and having now we've got most of the new executive in place, to have a dedicated meeting to look at all these issues with you and your colleagues. I think that would be helpful.
Sure, and we would absolutely recommend or be pleased to attend a meeting led by the council. It's an area that we absolutely would like to get closer to. It's really important that we share our experiences and our challenges with the local authority here. So that engagement is very welcome.
All right, thank you very much. That's really kind. Thank you. And thank you for those. Councillor Arnold, anything to add? Yeah.
Thank you, Chairman. Obviously, the Chairman having just talked about a separate meeting on the estates, I think that would be a great idea. Presumably you don't have any sort of time frame of when you think, as the new management team, you would have a plan and an idea in place?
We have an indicative programme developing in relation to development of the strategic outline case, with a view that then following due process of outline business case and full business case, I'm pretty sure that we were able to share that with you. It is an indicative programme at the moment, and as we gather maturity around that, so I'm sure that those programmes will be tightened up. But we're on a pretty fast track for it.
Wonderful. We look forward to that information. Secondly, in the past, and obviously you won't necessarily be aware, there's been obviously a problem with A&E targets being met at Hillingdon Hospital specifically. We were assured, I think it was last September, that we would be at national standard by March of this year. Are A&E targets now being met? And if you don't have the answer now, could you get back to us?
I'll come back to you on that one.
And just finally, you mentioned that you've almost finished the management team. There's still a few people left to put in there. How many people exactly? When do you think that management completion will happen by?
We're about to employ our Chief Operating Officer. That appointment has been made with simply it's a timing issue. And we then have one further appointment to make.
Thank you. That's all from me, Chairman.
All right, thank you. As you may have heard earlier, we split the main responsibility of the trusts between members, and both Councillor Mullally and Councillor Arnold are the ones who hone in on THH, so you'll be hearing a great deal more from them and from all of us later. But for now, thank you very much indeed. Thank you. All right, so the last few, thank you very much for your staying. We'll deal with Vino first, then Caroline, then Turkey. Thank you.
Thank you, Chairman. As you know, we don't normally give a formal presentation, but just a GP update. The biggest thing is the new contract that GPs have been given, and the move towards working in more collaboratively. So the move is towards a network of practices, a group of practices which are largely co-located around a certain area, region, looking after patient size cohort of about 30 to 50,000 patients. And that's recently been launched this month. So the way patients are going to be treated, although patients will still be registered and your GP will still be your GP, that practice will still be responsible for you. There will be some services which will be delivered by a group of practices in that network, or we call neighbourhood, if you like. And I think that's going to be the biggest change that patients will feel. Patients probably haven't felt it yet because it's only just recently, the deadline's just only just started. So, but that's a big change to the way we work as general practitioners. So from working in a practice-based setting with your team, and obviously liaising with allied healthcare professionals, there's a much more move towards collaborative working in a group of practices, and sharing the delivery of some services.
Mean that not every practice will do everything that they have done up to now, and that if they essentially want to refer a patient to another practice within the family or neighbourhood or whatever it is, to pick up on that service, and they go to that other building, but are referred by their home practice, as it were.
So the practices have either GMS or PMS or an APMS contract. So there's services which are core services, which all practices are mandated to provide as part of that contract, and that's not going to change. That's still going to continue. So all practices will be expected to provide those core services. It's additional services. So, for example, this is just an example. Some practices do some services, and other practices do others, depending on the interests of the GPs in that practice. So, for example, with diabetes, some practices offer insulin initiation in the practice, and in other practices where those services aren't available, there are other services such as the hospital. There's also the HESA clinic in the south. Now, this is completely dependent on what the networks decide amongst themselves. It's the network's decision, and they have a clinical director, which is a GP, which is almost responsible for overseeing the network. And there's no reason why, if one practice, for example, that doesn't have those expertise, such as insulin initiation, there's no reason why that service could be provided on a network level. So they refer patients on to another practice purely for that service. But again, this is just an example, and it's can be variable depending on each network and what they feel is best for their patients. So I think most networks have been approved. There's a few networks which are there's a requirement to have at least 30,000 patients, and some works are still a few thousand under. But as far as I understand, 6 have been approved, and the others are pending, depending on how we're going to work going forward. There are 2 practices which are not part of networks, and that's ongoing discussions and finding a resolution. But 6 practices, six networks are up and have been approved and up and running.
but I've seen something somewhere that said that the practices that haven't joined the network, they have to find a way of giving their patients access essentially to the network's facilities. Is that right?
So yes, so that's sort of a solution that has been proposed. However, there's governance issues in terms of getting access to the patient list, and obviously GDPR issues. So there's still ongoing issues, and this hasn't been resolved yet. So this is still in discussion with the practices concerned. So we're trying. Yeah, it's watch the space really. Yeah, Caroline.
I was going to say, hopefully Vina's just covered off one of my points in my update, so I can do that a bit quicker. But just on that point of the two practices, there are lots of conversations going on. Although it's two practices, it's one GP that is the partner for both of those practices. So, and we are continuing to communicate very closely with that GP and try and work through what they feel the barrier is, because the information sharing agreement for the networks is approved. It's a nationally agreed information sharing agreement, and I think currently in London, if not nationally, we might be the only area where we've still got they're the only two practices that have either not agreed to be part of a network or even allowed their patients to have services delivered to them as part of a network. So we've escalated that, but we're continuing conversations.
All right, thank you. Anyone got anything else for the GPs? We pick up a lot of this material in the GP Pressures group, and that's going to be reporting fairly soon. So I've always thought there was going to be ongoing work as far as that was concerned, and that's probably one of the areas that we'll need to pick up on. But for the moment, thank you very much, Indy. That's great. Thank you. Right, Caroline. I think the headline, the biggest issue as far as CCG is concerned is the case for change, which has been being talked about a lot. And I think you know what our views are, I think, in terms of our concerns about and I think Vino's quite involved in this as well in terms of views. And some of those issues were picked up at the Health and Wellbeing Board. And in fact, today, Councillor Cawthorne and I had a discussion about a range of issues that we're very concerned about, because I know he's seeing the person at the head of all this in the next few days. And it is a great concern. I know there's a head of steam for it, but we just cannot see the advantages, and we can see far too many disadvantages and losses from it. And with that happy note in mind, I'd like to give us your update.
Oh gosh. Well, I mean, I suppose I've appended the case for change. I'm happy to take questions about it. I've already done this lot at our annual general meeting this afternoon, so I'll try and think about what the key messages from that were. I think we are absolutely clear and know ourselves, and also hear from stakeholders and residents, that there are really highly valued elements of having a local CCG. And some of that is around having the local clinical leadership and the opportunity to have those clinical leaders have those conversations with other sort of clinical stakeholders, be it our providers or LMC colleagues. Some of it is about local accountability and having that sort of direct contact point into the commissioning of healthcare. And some of it is about relationships, because actually at the end of the day, lots of this comes down to actually knowing the people around the table and being able to have open and challenging conversations, and doing that in a sort of environment of prior knowledge of each other and sort of trust and respect. So I think those are some of the things that we've heard so far in terms of the engagement process and the consultation that is ongoing. The consultation period initially was going to end on the 24th of July, but has now been extended until the 24th of August. So people are sort of remain free, obviously, to feed any thoughts or comments back up to the North West London team that are collating this. I suppose I'm slightly conflicted in as much as I am kind of the Hillingdon CCG managing director. I suppose if I do look for things that could be positive about it, I think it's really in the lens of not necessarily what Hillingdon would be losing, but what would need to be there in the place of a CCG. And a lot of work and a lot of conversations happened around integrated care partnerships and what that might look like. And going forwards, I suppose some of the questions are those local points of contact, the local clinical leadership. Actually, how much do things like the primary care networks play going forward? So, if we get 8 networks up and running, we'll have 8 primary care clinical directors who will be a very valuable resource for us locally in terms of developing clinical leadership in primary care. Conversations currently about how we retain some of our clinical directors who are on the governing body, and what might a local team or a local borough presence look like are being worked through at the moment. So that's sort of the next iteration of communications that will come out, and which I hope will be available before the meeting with Councillor Cawthorne. And I've been invited to that as well, so I will have a third go at talking to it. And I think that there are some opportunities in as much as some of the things that we do on a sort of daily business as usual basis with some of our providers are quite transactional and contractual, and actually probably some of that could be done at a system level, leaving people a bit more time and capacity to be able to do some of the transformational bits, really focus on some of the quality side of things in a less maybe a less contractual way with our provider colleagues. So and really focus on outcomes and trying to reduce some of the variation that we see through some of the mechanisms like primary care networks or the integrated care partnerships. So I think the challenge that we have at the moment is that hasn't necessarily been articulated particularly clearly as to what the future could look like. At the moment, there's just a lot about sort of CCGs now and what they might look like if it's a single CCG, as opposed to what some of the opportunities might be around integrated care and how we might do things differently rather than just try to create a mini version of what we currently have. So I suppose that's a sort of watch this space and maybe let's see whether there's anything that comes out of the next stage of the consultation process or the engagement process that gives a bit more detail around that for people to look at.
I suppose, very conscious of the time, but I suppose the biggest fear, in a sense, that we've got is that looking at the geographical spread as is envisaged, that because we are, as a local health economy and a local health landscape, we feel in a good place and are fairly far ahead of a lot of the others that make up the Northwest region, that these sorts of changes in the NHS, or frankly in any large organisation, especially state organisations, do not tend to make things better. They tend to even out in a way that the better places become less well because they've had the quality sucked out of them, sort of thing, to make it more even an average. And that's not something that we want to have happen, and it's obviously not something that you want to have happen, but in the sort of notion of a greater good could easily take place. And you're right that at the minute we're sort of fighting against something that is being talked about without knowing what's in its place, but equally we don't really want to lose what's in its place currently. So I know for those reasons that's the sort of thing that will be taken up by Councillor Cawthorne later. But as you say, it's probably difficult to envisage because we don't know at the moment. All right, does anybody else? Councillor Vadia.
Thank you, Chairman. Caroline, I just have a few questions about the merger. I mean, personally, I think I do understand that we need to find huge savings in the NHS, and I get it. But for me, as long as whatever the new organisation is, the combination of the CCGs is still responsive to local needs, and we have that connection, and there is this sort of two-way relationship that we have with you, and that continues, I'm comfortable, because ultimately this is also taxpayers' money, and we have to find that balance and realise that demand on the NHS is only going in one way. I know that CCGs are the CCGs that will merge are in various sort of financial positions, and I imagine some are in deficit, and some are not. And I wanted to know what Hillingdon CCG's financial position is, so we can sort of understand whether we would be a net benefactor or a net contributor financially as a result of this merger. I haven't read, I know it's going to save money, but for comparison purposes, it would be good to know what the actual cost of the merger is, so we get an idea of the scale. And I didn't read anything in it wasn't your report anyway, it was the one put together by the Northwest Group, how GP practices are feeling. Perhaps Dr. Siri can talk to us about how you think GPs are going to be affected, if at all, by this change. And I also wanted to know at what stage you are in developing your integrated care partnership and whether you feel your partnership is compatible with the ICP that the other CCGs are developing.
Okay, so in terms of the financial position, our control total for 1920, which is basically what the regulators measure us in terms of whether we're going to hit or not. So our plan is a 1.7 million deficit for Hillingdon. I would say that probably puts us in the middle of the pack, to be honest. So Harrow have always had a very significantly challenged deficit position, so they're in the double figures in terms of their control total, and then there are a number that are in the sort of 1 to 5 million deficits, and then there are some that are, I think there's one that's currently forecasting break even, and one forecasting a surplus, and that's, we call them West London, but that's Kensington and Chelsea. And they have historically always had a surplus for sort of vagaries really around the allocation formulas. So there is something that has historically happened around the way that finances have been allocated to different bits of the NHS, and particularly I think in London as to the way that the weightings disproportionately impact different boroughs. And you do get, we call it the sort of the donut effect around the outer boroughs versus what the amount of funding that necessarily goes into some of those inner London boroughs. So I'd say we're pretty much sort of in the middle of those financial positions across northwest London. Certainly in the immediate term, CCGs have had their sort of provisional allocations announced for the next 5 years. So in the short term, as in, if this were to happen from April next year, there's no proposal at the moment that those budgets would move across CCGs for now. So there's an allocation that comes to a population. How long that stays, because one of the stated aims of this piece of work is to drive out unwarranted variation, and some of the unwarranted variation is the unwarranted variation in the finances that go to the different bits of the patch. And that is something that at some point I think we'll have to look at if we're serious about releasing the benefits of what we are putting together here in terms of the case for change. In terms of the cost of merger, so at the moment there aren't any figures. I mean, really what we are hopeful of is that sort of colleagues probably know that CCGs have a management cost reduction target. So we are supposed to be delivering a 20% reduction of our management costs from our 17-18 baseline. So we've had 2 years really to try and deliver that, and that will continue. Actually in Hillingdon we are already beyond that. So we run a very lean, small but well-formed machine in Hillingdon. So we are very hopeful that we are able to just sort of maintain the teams that we have locally. And across northwest London, the hope is that really just from natural wastage of people moving on over the next few years, that there shouldn't be a huge cost, certainly not in terms of things like redundancies or people having to lose roles. Actually, that should be quite organic in terms of being able to retain people locally. But at the moment, there's no sort of stated figure around that. And then I'll just pick up on the ICP point before I hand over around the GPs. So in Hillingdon, and again I kind of stressed this afternoon at the AGM, I think, although I am probably slightly biased, we are ahead of the pack, and some of that is because of the geography that we have and the fact that we have a hospital bang in the middle of Hillingdon, whereas other boroughs in North West London like Ealing tend to see a sort of five-way dispersal sort of patients out of the borough, as well as sort of using the hospital in the middle there. Their patients go to Hillingdon, Imperial, sometimes out of North West London, but we have an 85% sort of congruence really with Hillingdon Hospital. So we've been able to have really sort of good and coherent joint planning with the hospital around what integration looks like for us and with our partners at CNWL. So really over the past 5 years, to be honest, we've been talking about integrated care partnerships and bringing something to bear in Hillingdon. And actually we already have some of the models of care that you would want in a integrated care partnership. And coming back to the conversation about the winter planning, one of the things that worked well and still seems to be working well, touch wood, is we put in place something called the Care Connection team, which was about the CNWL district nursing teams working really closely with the GPs, and then also a frailty unit at the front end of Hillingdon Hospital, so that all of those healthcare professionals could work together to try and prevent people being admitted into hospital, and when they were admitted into hospital, ideally with no longer than a 72-hour stay, and that is all the fruits of the geriatric consultants in the hospital working with CNWL, working with the GPs to really think of new ways of doing things. And equally, we have something around paediatric clinics as well. Sorry, this is my slight hobby horse, but we've had a really good uptake of paediatric consultants working in primary care, so that families don't have to go into the hospital. They can go into their local GP practice. It's a much nicer environment for the children to go to. And the paediatric consultants like it because they say it's actually much easier to then discharge those patients back to the care of a GP because they've had that conversation with a GP, and the patient's not institutionalised then coming back to the hospital. So it's just an example of how we've been working with older adults, but then also with sort of children and young people around trying to really manage demand into the trust. So that's really what the integrated care partnership is about, and I think we've got strong relationships with all of our partners around the table. And actually North West London are looking to us to kind of lead the way and test some of those integrated ways of working. So that is a bit of a selling point for us in Hillingdon to try and preserve what we do have around integrated care.
Sure. So in response to what GPs feel about the merger, so if you look at funding per patient amongst the boroughs, and it's almost, if you have sort of central London in the middle, and then you've got Hillingdon out here, and then you've got on the other side you've got the sort of East London CCGs. It's almost like a bell shape where the central London are very well funded, and the outer London it's not as well funded. And when I speak to GP colleagues in sort of Kensington, Chelsea, Westmead, they just wouldn't be able to cope with the funding that we receive in Hillingdon. I can't see, this is my personal view, I can't see with the merger, I mean, slowly with time that actually is getting a bit more flatlined and funding being equally distributed. But with the merger, my own personal views, I can't see that situation getting any better. Purely because partly because of where the geographical location where Hillingdon is, and whether the views of Hillingdon GPs would be taken strongly into account. We don't know. I can't comment because we don't know what the future holds. It's all question marks, but it's just my own personal view.
All right, thank you.
So, but on the GP point at the moment, we are saying that any change would need to go to a vote of our GP membership. So at the moment, the way that clinical commissioning group constitutions are set up is that any change to that constitution needs to be voted on by the membership. So to make any changes, the GP members would have to be bought into it, because otherwise it couldn't happen.
Right, that's very good, thank you. Unless anybody's got any other questions on this, thank you very much. Okay, sorry you draw this short straw tonight, being left last, but thank you for being here. And some of it may have been of interest to you, perhaps all of it may have been of interest to you. But a quick romp from you would be great, thank you.
These meetings are always useful for us because we pick up an awful lot of information, and it helps us to sort of close the loop in terms of what we hear from the public. I mean, I just want to echo some of the comments made about the merger, or the possible merger, in that from a HealthWatch perspective, our worry is about ensuring that locally the local population needs are met, and we still have those avenues of communication to feed back the concerns that are raised with us. And at the moment, those avenues of communication are very good in terms of the CCG. We've got one or two challenges in other places, but we're working on that. But generally, when I talk to other health watches, our communication routes and our partnerships is very good, and we don't want to lose that. And we've just published our annual report, and last year directly we actually had just short of 3,000 people contact us in terms of health issues and so on that we've been able to help. And so if we don't have this kind of close partnership, we would wonder where that kind of information would go to impact really in terms of the quality of delivery that we're currently able to do, through such reports as the lower back pain report, through the work we do with Young HealthWatch. I mean, indirectly with Young HealthWatch, we probably reach about 3,500 young people, because those youngsters go off and do stuff in their schools. They run assemblies. They're running the Health Fest events again this year. In fact, we ran one last year. We're going to do 3 this year. So all that kind of activity helps us with information which we freely share with CCG and other partners. So we would worry about how we'd be able to get that back upstream, as it were.
Yeah, I think it's interesting what Caroline said about others looking at what happens here as a model. Again, that's one of the big concerns, that we would lose that community and partnership working with a centralised CCG, because we question how would a much more centralised operation have a, for want of a better word, a feel for the borough, and similar for others, if they're going to get that way. And that's why we worry about a lowering of a sort of common denominator. Any other issues that HealthWatch want to pick up on, or are you?
Well, just from our perspective, we've published our sort of high-level agenda for next year, and we will be revisiting the discharge issue at the hospital in the new year. We're going to do some work around mental health, using Young HealthWatch to look at CAMS, and then ourselves looking at the adult end of it. And we are also going to do some work, which is our first sort of bit of work around care homes, because I know CCG and the local authority have invested in care homes, and we want to get a baseline so that we can go back later and to see whether that investment is having a positive effect on people in care homes.
We've got a document before us on the discharge review update, so we've all seen and read that, and we know that it's being come at both by us and by the Social Care Housing Public Health Policy Overview Committee, and maybe it's something that we'll return to at some point later.
If HealthWatch Hillingdon are going to be looking at the issue in future, the review was previously undertaken, our review, because I understand you to do a review as well, our review was previously undertaken by the Social Services POC, the Council's POC, and we have an update paper from officers here on that. I'm suggesting to the Chairman that actually when you have produced your update report on hospital discharges, that actually we look at that.
Certainly. I mean, ours won't happen until the new year sometime. We would have visited earlier, actually, to see what happened since our last report, but because of the inspection and where the hospital's at, it didn't seem any point.
I don't see why you shouldn't get a copy of this, so it helps to inform your thing as well, because, I mean, it's a public document, so I think...
Well, it's a briefing note, I'm sure.
No, briefing note, but briefing note, public, one person's briefing note, the other person's public document. All right, that's very good. Any other comments or issues on this one? No? Okay, thank you very much. All right, thank you to all our guests and witnesses and regular attenders, and that's been great. We've had a great deal of information, and we're very grateful to you all. Thank you. Right, members, quickly, a quick romp through the work programme. Nikki?
Okay, you may have seen that I have moved all of our meetings into this room now. They were previously booked for committee room 6. The camera doesn't pick up all of the witnesses around the table, the view from the camera in this room is much better, is much further back, so therefore it's picking up more people. As we've just mentioned, the hospital discharges review, it was on the agenda for tonight, but because Michael Sobel was going to be such a big item, it turned out in the end, was unanticipated until the very end, I asked officers to provide us with an update report instead. So that's been circulated to you all. I do apologise for the lateness of it. It only came around yesterday. If you do have any questions on it, please let me know, and I will go back to officers to get answers for you. And finally, in the recommendations on page 67, there are two things I've itemised there that I'd like direction on, please. One is the topic that you would like discussed at our next meeting in September, which is our crime and disorder meeting. And then I need some dates for the bowel cancer, cervical cancer, and breast cancer screening in the borough, because we want a meeting on that separately, and another one on the Mount Vernon Cancer Centre review. And from tonight, we also want another meeting on Hillingdon Hospital.
Well, I suggested, as we were going along, that it might be an idea, given the state they're in, that we factor in a joint meeting about just about two matters. One about Hillingdon Hospital, and with the new executive committee, because most of them, as Tahir said, the longest one that's been in is 6 months. So maybe we could have a meeting partly devoted to that and partly devoted to a much better understanding of the CCG position. Councillor Arnold.
Councillor Mullally and I was saying, would it be possible for us, prior to that meeting, to have a site visit at the hospital? Whether it's just us two or everybody.
Yeah, we've in the past we've gone over and had a look at stuff when the former team were in. It was quite some time ago, about 3 years ago, I think.
But I think the time.
But yes,
timing would probably be just be. There's no point in us going now, and then we're not having that meeting for 6 months. But
I think we should. I think we should. It was interesting. I thought I heard Tahir say that they were appointing a new CEO, but I thought they'd got one already. Chief Operating Officer. Okay. Well, maybe once they've got that person in place, go over and have a tour around and have a look. Nikki can sort that out with them. That's great. Okay, yeah, good idea. Anything else on the work programme? I think it would help if we did have a dedicated meeting for those two topics. If we can fit it in the normal plan. I don't want to create too many. Thinking? I don't know. Towards the end of the year?
December, November?
Oh, I see. I think it'd be fun to do it in December. About the 24th. On the same night as our Christmas party. I don't know. We'll talk about that later. But maybe towards the end of the year when there's been a bit more time for things to happen.
Can I ask members then to, as far as the crime disorder meeting is concerned, if you can email me with any suggested topics by the end of next week, so I can then get on to officers.
I'm always going to say knife crime, but I know we've talked about it before. But it might be if there's no other ideas as far as specific stuff to tackle, it'd be good to have a specific meeting or specific conversation on knife crime.
Oh, sorry, Councillor Roger.
I'm always keen to hear from the police about drugs and drug crime.
Councillor Andrew.
I was just going to ask, what type of topics are covered? Because I'm new to the committee, just to arrange.
It's not so much topics. It's the Crime and Disorder Reduction Partnership comprises public health, fire brigade, CCG, police, and I think the council generally, so our antisocial behaviour. And it's things that they actually work together on. I think did I not send you a copy of the reports? I may not have. There are a number of reports that we've had previously where they have targets for burglaries, for theft of vehicle, physical violence, those kind of things. They have actual targets that as a group they have to work towards reducing, and they set their priorities at the beginning of the year.
It's the flip side to our health responsibility. Essentially, there's two sides to the committee. One is health-driven, and the other is police and other civil services, or not civil service as such, but civilian services. And it's part of our statutory duty to scrutinise and review their work as well as the health partners. So it's a two-sided thing. And on that meeting, it is particularly focused on the on police and public order.
And we don't have leads like we do for the health side of things. It doesn't work.
No.
Okay.
Councillor Brightman.
Thank you, Chairman. I realise that I'm not here, but I'd suggest the Serenity Integrated Monitoring would be quite useful to see what the police perspective is of how that project's working as a follow-on from this week.
That's a very good idea. Councillor Dennis needs to watch out. Sitting at home watching this, quivering as he speaks. All right. Any other ideas for the moment? If not, we can send them in to Nikki in the next week or so. Councillor Latman.
I think with the knife crime, if we can add safer neighbourhoods, combine that.
Oh, and nothing to do with this, but this idea that I had about us sending a sort of overview note to this meeting on Thursday. I mean, it was just something that came to me. Did you think that was a good idea to do that? I'm not, yeah, I mean, it just seems to me that emphasising to them how strongly we and representing all of our residents feel, and the fact that they're not providing anything at all at the moment, clearly not, might help to shift it along. And if they don't come to a solution on Thursday, and there's a very good possibility they won't, because they're wrapped up in all sorts of procedure and concerns, then we will get them in, and all the parties, and just hammer it out, because otherwise it will drift. And it only drifted this time because we didn't know it was happening. And as far as the CCG were concerned, it should have been happening, but the East and North Herts just yet again managed to find a way of it being slowed down. But there we are. All right, Councillor Roddia.
Chairman, do we know why East and North Herts didn't turn up this evening, and did they send their apologies?
I had an email from David Brewer to say that he would let me know who was coming, and Nick Carver, the Chief Executive, provided me with an update on their standing of the situation, which I have circulated to everybody. He said that he was unable to attend at such short notice because, in fairness, I did contact him late, but I had contacted Rachel, Sarah and David middle of June, and David did say he would get back to me to let me know who was coming, and didn't.
Chairman.
Just
on that point, if they don't come to an agreement on Thursday, or the 11th, sorry, is there anything we can do? I mean, like legally, or put bigger pressure on them? Or?
Not at this time. There is an enormous complexity about the relationships between the various parties, and the fact that there is no formal documents that tell you who is responsible for what, and we now know that, and I think we knew that a little while ago because we dug, and eventually it was discovered that there were no formal documents, and there clearly should have been, to set out parameters, to set out responsibilities and all that sort of stuff. And so it makes it very difficult when you've got an external provider, external to the borough, to do much more than that which we have been doing, which is putting pressure on by doing things outside the meeting. Because if we couldn't leave things just to happen within our meeting cycle, because it wouldn't be practical. So each of the parties has been seen separately to see where they were on the track fairly early on after our meeting in February, and we were quite happy with the fact, and you know all this, we were quite happy with the fact that that things appeared to be going along well. Where it went wrong was because there are quite so many commissioners involved, and one of them has the relatively equal percentage share majority with us, and they have been slow in coming to a decision and then sort of reversed it, and now apparently may not have reversed it. But that's because of how they work, and we don't, as a borough, we don't have any traction over external commissioners, let alone external trusts. What we do have is a great deal of goodwill in terms of how we deal with these other people. And so keeping that going has been something that's been quite important, I think. So being able to have conversations with them offline, I think has been productive and has moved things forward to the extent that they've been able to. If it was our own people, we could do something more, but we can't because they're external. So, as I say, I think the best thing, because they all seem to be saying we want to go in the same direction, and have said so in public, most of them anyway. I mean, we haven't talked in public to Harts Valley. I think that the idea of getting them all together in a setting where we can essentially bang heads together and get a decision and find out what the problems are is quite important, really. So that's what we'll be doing. Councillor Riley.
May I suggest that when we discuss the Mount Vernon Cancer Centre, that we also perhaps allow time to revisit this issue? And I tell you why, because Mount Vernon Cancer Centre is probably going to close now, and they're looking at moving the Mount Vernon Cancer Centre, the wards in 10 and 11 that we keep discussing, actually somewhere completely different. That's the latest thinking coming out from E&H, and as a result of the current review, I would not be surprised if the review concluded that actually the whole centre needs to close down and be moved. So that might also affect the future viability of the hospice. So if we do look at the Mount Vernon Cancer Centre, and I believe we should, because it may well be moving to another site quite far away from us, perhaps given the knock-on implications to MSH, we should look at them together.
That's certainly a possibility and probably a good idea. However, I think that I'm not sure how much the two are combined. As Caroline said, they'll be looking on Thursday to find out why East North Hearts think that there is any effect of one on the other. The cancer review will report, I think, next week. Is it next week? I think it is. Yeah, it must be next week. Because it was started, this is the cancer care review as opposed to the hospice review. It was started because there were very grave clinical concerns on the part of various groups about the effectiveness and quality of delivery of cancer services on the site. My understanding is that none of those services are provided locally. They're provided externally. Again, because of the various commissioning arrangements. They're provided on the site, but they're commissioned externally. So I don't understand that THH, for example, commission cancer services to that site. It maybe they do, but I'm not sure that they do. I think East and North Hearts are the larger, if not the only, commissioner of services to the site, and they pay for it and all the rest of it. So if the report, and I'm speculating wildly, but if the report comes down on the idea that it's not viable because of the nature of what's happening there, it won't be so much a question that the effect will be the same. It won't be so much a question of East North Hearts sort of moving their services. It'll be that they'll be told that it's no longer viable to run them at that site, and therefore it'll have to be run somewhere else. Now, whether other cancer services are then picked up to be run at the site by other commissioners, I don't know. But the report is about the viability of keeping going what's there at present. But I'm not convinced at the moment, and it may be it is, I don't know, but I'm not convinced at the moment that there is such a big relationship between those services and the hospice services. There may be, but maybe there isn't.
There's an interdependency between wards 10 and 11 and the hospice.
Well, all right. Well, we'll see what comes out of the meeting on Thursday, but it's a good idea to pick it up when we do that. All right, thank you. Any other points that we want to raise? Okay, I'll declare the meeting closed.